rate goes up,
excision rate
and your
goes
number of
up.
melanomas per patient.
Well, a lot of
goes
people, it's a little controversial. Not everybody likes number needed to excise, but that is one metric you could use, which is how many, like an appendix, right? How many benign things are you biopsying compared to the malignant, right? So if you're perfect and you know exactly, it's going to be a 1-to-1, right? So you want that to be high enough so that you're not biopsying tons and tons of benign things.
One more question, please. Yeah.
Yes, mine's for Dr. Nelson. When you're marking out the area to show the patient what to treat with imiquimod, are you using a Woods lamp or are you just going off the scar?
Right. So if I'm doing adjuvant, where the patient has had surgery and now we are using the imiquimod to reduce the chance of longitudinal recurrence. So this is a patient who, in theory, has no clinically apparent melanoma left on them. So I'm still looking at the Woods lamp to make sure there's no melanoma that I can see. These are patients who I'm looking at them. I've looked with Woods lamp. I don't see any melanoma.
Well, if you use the Woods lamp, you can mark out your lentigo malignant like if you do a biopsy. Like I do a lot of excisions. I probably do 30 or 40 a month lentigo malignants. And I always mark out, I put the Woods lamp on, a lot of times I'll see pigment way out past what you clinically see with your eyes. So I was just wondering if you use that, because I do that. I do imiquimod and I'll use the Woods and I'll mark it. I just didn't know if you did it because I was trying to figure out, I'm going a little too far with it. You know what I mean?
Right. So there's, yes. So if you have a patient in front of you and you're trying to determine the clinical extent of disease, yes, Woods lamp is enormously helpful. Woods lamp and dermoscopy can really help you determine the extent of involvement. Yes.
And another thing is, does your center have experience with cryotherapy? Because I've used a lot of cryotherapy in the unresectable ones, the very large ones, and then I'll use imiquimod after it heals, like 3 weeks later, 4 weeks later. I've had really good success, so far. I have probably 8 years of follow-up with with the oldest ones. And so I
That
just wondered if you
IDS
use cryo.
paper, Kelly, that you referenced has a very short section on cryotherapy or cryosurgery, which used to be used with cryoprobes in the past, but I don't think it's commonly used. But, I think you'd have to worry a little bit about masking.
I usually mark it with the Woods and then do like a
Do the Woods
30-second frost, 2 cycles. So it's more extensive than usual. I just was curious.
Got it. I think it's certainly listed as one of the things that you can consider in your options for melanoma. We know that melanocytes are very sensitive to cryotherapy.
Thank you both. Good luck getting to the airport. And this has cut a little bit into our panel discussion, but appropriately so. So thank you guys very much. Our next speaker is Dr. Kelly Cha from the University of Michigan, and she's going to speak on biopsy techniques and primary surgery.
Hi, it's an honor to be here this afternoon. Thank you all for being here as well. I have no conflicts of interest. I have 2 main learning objectives. First, to review the recommended techniques for biopsy of a suspected melanoma, of course, with the primary goal of obtaining an accurate assessment of histologic prognostic parameters. We'll also talk about the risk of inadequate diagnosis and the risk for metastasis, and detour into a couple related topics of special interest to me, including biopsy site photography and anatomic designation. We'll also talk about guidelines for surgical management of the primary site. The primary central question is, what is the optimal biopsy technique when you suspect a melanoma? And there are 2 goals. First, of course, to obtain a diagnosis and critical prognostic information, specifically an accurate Breslow depth, while also preserving the conditions for appropriate future treatment for your patient. As a reference, I'm showing the latest NCCN guidelines for principles of biopsy of a suspicious pigmented lesion. These are similar to the AAD guidelines that Dr. Sweater mentioned, published in 2019, and I'll go through these in more detail in the coming slides. First, an excisional or complete biopsy with 1 to 3 millimeter margins is preferred. This can be accomplished by elliptical, punch for smaller lesions, or saucerization shave removal. Narrow margins are recommended over wider margins to allow accurate subsequent lymph node mapping. In the United States, among dermatologists, saucerization shave removal is generally preferred, and it's illustrated here. Centrally, the brown cells represent an invasive melanoma, extending, as you can see, into the dermis, and the wider dotted line shows the trajectory of a deep shave removal. The intent of that procedure is to completely remove the entire clinical lesion and to obtain an accurate Breslow depth. without compromising subsequent treatment. This is distinct from and preferable to a smaller shave biopsy of a portion of the lesion, which is illustrated in the smaller dotted circle. This photo illustrates a lesion clinically suspicious for melanoma on the left, both prior to and after a deep shave biopsy. You can see that the biopsy, this technique allows you to go deep into the dermis, but not into fat as a punch biopsy or elliptical excision would. But it does allow you to remove the entire or the majority of the clinical lesion to obtain an accurate depth. In this particular example, the brown area is not residual pigment, but just serous crust. But if you do find after a shave removal that you see residual tumor or pigment at the base, then a deeper biopsy is recommended to be performed immediately in that same visit and submitted separately to the pathologist. That, in this particular case, you can add the Breslow depths of the two specimens to obtain the most accurate Breslow thickness. So there are downsides to getting a partial biopsy. This is a photo of a 32-year-old man with a 1.5 centimeter pigmented nodule on his back. And in this particular case, a small shave biopsy was taken from the upper left area. That shave biopsy showed a Breslow depth of 0.7 millimeters with involvement of both the lateral and deep margins, no ulceration. There are several possible next steps that you could take. You could repeat a biopsy to obtain better more accurate Breslow depth. You could proceed for treatment with the biopsy parameters that you've obtained, or you could consider that if the deep margin is positive, perhaps instead you would like to go ahead with the margin appropriate for a deeper melanoma and even consider sentinel node mapping. Whereas in contrast, if you had biopsied the entire lesion in its entirety, you would have been able to see that the Breslow depth was 1.2 millimeters without involvement of the margins, increasing your confidence level that you've got the appropriate Breslow depth. And that would lead you to more clear guidelines of a wide local with 1 to 2 centimeter margins and a sentinel lymph node mapping. This example is not particularly unusual at our institution. We published a study a number of years ago with microstaging of 250 patients who had more than half of the clinical lesion remaining after the first biopsy, and 21% had upstaging of their melanoma, and in half of those, the patients became candidates for mapping when they weren't previously. Here are two more examples, and you saw some earlier too, where partial biopsies don't necessarily reflect the true Breslow depth. On the left, a punch biopsy showed Breslow depth of 0.5 millimeters. On the right, melanoma in situ, but on complete excision, both lesions reached a Breslow depth of 1 millimeter or deeper. So to summarize, if the initial biopsy is adequate for your confidence in your Breslow depth, then you don't necessarily need a further biopsy, but if you don't feel confident in your Breslow depth, then a repeat biopsy or microstaging is warranted. If we turn our attention specifically to excisional biopsies, the main goals, again, are to obtain an accurate diagnosis while preserving further treatment options. So if you're planning a biopsy on an extremity and you're considering an excision, this should be oriented parallel to the extremity in order to allow further lymph node mapping to be as accurate as possible. There are definitely some situations where the lesion is not as well suited to deep saucerization, and that could include a lesion where your suspicion for melanoma is low, or if it's a concerning pigmented lesion on skin with high cumulative sun damage, like the face, where a patient is not interested in a deeper shave biopsy. In those cases, you could consider a broad shave biopsy extending into the deep papillary dermis, illustrated on the bottom right. As you know, there are additional clinical scenarios where you may not want to consider a deep shave biopsy, for example, a larger lentigo-maligna melanoma, acral or subungual melanoma, or bulky tumors, and I'll show photos of these. In this case, for example, it would be very impractical to perform a deep shave biopsy of the entire clinical lesion, but your goal still remains to obtain a diagnosis and help guide further treatment. So in this case, it may mean helping to define the extent of disease with multiple scouting biopsies. For acral melanoma, this can present technical difficulties in obtaining a deep or complete saucerization, so you might consider a partial biopsy of the most clinically concerning portion, always, of course, balancing the benefits of a partial biopsy with the risk of obtaining incomplete information. When you have a large bulky tumor that's suspected of being melanoma, again, the guiding principle is to obtain a biopsy with an eye toward future treatment. So in these cases, a biopsy is needed to establish the diagnosis, but biopsy of the entire lesion would not be practical, nor would it be critical to inform the next steps of management. Nail lesions present a special diagnostic case. Typically, the relevant concerning pigment is in the distal matrix, and an adequate biopsy would require sufficient reflection of the nail plate. So a tangential shave is preferred unless the bandwidth entirely fits in a 3 mm punch. Misdiagnosis can occur if you biopsy only the Hutchinson sign. Switching gears a little, just a comment on hemostatic agents. Topicals are preferred because they won't eradicate any underlying melanoma, like electrofulguration or electrocautery might. If Moncell's is used, it should be documented so that the resulting confounding pigment in the dermis, as illustrated on the left, won't cause any future confusion either clinically or histopathologically. In terms of the influence of biopsy technique on the risk of metastasis, there have been a few very reassuring studies. One is the Sunbelt Melanoma trial. Nearly 2,000 patients were subjected to a biopsy of suspicious pigmented lesions, many by excision, but a fair number by incision or shave biopsy. All the patients in the trial then underwent wide local with sentinel node mapping, with a mean follow-up time of 28 months. And they found that the biopsy technique did not affect the rate of sentinel node positivity, nor the rate of recurrence in these patients. A more recent systematic review and meta-analysis also showed no impact of shave biopsies on local recurrence or survival. So to review guidelines for melanoma biopsy, what's recommended is an excisional or complete biopsy with narrow 1 to 3 mm margins for accurate staging of a lesion, and the depth of the biopsy should be sufficient to avoid transection of the invasive component. If performed, an elliptical excisional biopsy should be oriented longitudinally on an extremity to optimize the subsequent surgery and minimize the disruption to the underlying lymphatics in the event that mapping is indicated. Partial biopsies are very reasonable in select clinical circumstances like facial or acral locations when your clinical suspicion is low or if there's a very large lesion. And you would consider a repeat biopsy if the initial biopsy does not give you the information that you need for confident treatment planning. I want to take a moment to highlight the importance of biopsy site photography. Correct identification of the biopsy site is required for appropriate treatment. Wrong site surgery is, of course, considered a surgical never event, but it is a significant risk in dermatology. This was one study within a single Mohs practice in which 271 biopsy sites were evaluated. The biopsies were all performed by providers within the practice. When the patients came back for surgery, in 83% of the cases, the patient could identify their biopsy site. In 94%, the provider could, and this is a best case scenario when it was the provider who performed the biopsy. So together, they came up with 96% of the sites, leaving you vulnerable to a 4% wrong site surgery rate without photos. With photos in this practice, they increased the confidence to 100%. So I would recommend biopsy sites always be photographed with respect given to proper lighting, focus, and consent. Ideally, the photo would be in the medical record, and especially if your patients are traveling elsewhere for surgery, in the patient's phone. There's a QI study published with a suggested algorithm with marking the lesion, magnifying, and mapping, and I'll just illustrate that. So on the left, the biopsy site was photographed, but it was after the fact, and not only would it be difficult to understand the relevance of the red rim, whether that's inflammation or part of the initial clinical lesion, but it also would be difficult to determine what anatomic site this lesion was on. On the other hand, on the right, you can see that the lesion is marked with a pen, and then two photos are taken, one magnified, an up-close photo that will show nearby cutaneous landmarks, and then one considered a mapping photo where you can see nearby anatomic landmarks, and it improves your confidence in terms of the anatomic site. Standardized anatomic labeling can also help. Precise, consistent labels aid in site identification and communication between physicians. Consistent language is helpful not only for patients, but also trainees and for our practices. And there's been increased attention recently to standardized terms for surface anatomy, highlighted in an August 2024 JAD CME article, which is illustrated on the right. I'm going to move on to recommendations for surgical margins in the last few minutes. The goals of surgical resection are, of course, durable local disease control and a cure for patients with localized primary melanoma. Margin recommendations have evolved significantly over the years, and they continue to evolve, as Dr. Sweater mentioned, and will be discussed by some of my colleagues coming next too. Prior to the 1970s, the recommendation was a very significant margin of 5 centimeters, which of course required general anesthesia, more complex repairs or grafts, and caused greater patient morbidity. This is an illustration of a patient who underwent a 5 centimeter wide local excision and naturally had a prolonged healing course and even shoulder mobility restriction, as you could imagine. Current guidelines are pictured here for your reference. As you can see, current margin recommendations are significantly narrower than 5 centimeters. For melanoma in situ, the recommendation is for excision with 1/2 to 1 centimeter margin. For thin invasive melanoma, 1 centimeter. Between 1 and 2 millimeters, 1 and 2 centimeters, and greater than 2 millimeters, 2 centimeters. In terms of surgical margins for melanoma in situ, there are not currently any published randomized trials to inform peripheral surgical margins or the depth. So by consensus, the depth of excision is intended to be into the subcutaneous fat, and especially in anatomic locations where excision to fascia would cause significant morbidity. For invasive melanoma, we have a number of trials, and these results taken in sum and kind of distilling out and applying logic have concluded basically with our current margin recommendations. All of these trials used standard excision, and few included patients with melanoma on the head and neck, and none acromelanoma. Most of these trials also examined current margins against wider rather than narrower margins. So surgical margins for the primary site, the recommended depth of excision is to the level of the fascia, which is typically preserved unless you see that it's involved by the tumor. Peripheral resection margins can be modified to accommodate individual anatomic or functional considerations, with the risk, of course, that narrower margins could increase the risk for margin positivity or local recurrence. Narrower margins then recommended, for example, via wide excision, Mohs, or staged excision for invasive melanoma on anatomically constrained sites are generally not recommended until further studies are available. In terms of peripheral surgical margins for the primary site, wider margins over 2 centimeters have not been shown to improve local recurrence, disease-free survival, or overall survival, including for T4 melanoma. We still haven't identified the narrowest, most efficacious margins for cutaneous melanoma, and there are several ongoing trials to consider whether we might narrow our margins for invasive cutaneous melanoma. Although, as alluded to earlier, sometimes for certain types of melanoma in situ, wider margins may be necessary. One of the trials that's ongoing to determine the efficacy of a narrower margin is MELMART-2, and in this study, approximately 3,000 people have been recruited with stage 2 melanoma, and they're following disease-free survival rates for these patients who have 1 centimeter versus 2 centimeter safety margins, along with mapping. The idea being that a narrower margin may lead to a difference in local melanoma recurrence or regional distant disease, but we can also assess the impact on quality of life, reduced side effects, and also the economic impact. With respect to clinical pathologic correlation, excision margins, when we're recommending 1 centimeter, for example, that refers to clinical margins taken at the time of surgery rather than gross or histologic margins measured by the pathologist. So typically, pathologists will not be reporting out to you what millimeter margin clearance that they'll see under the microscope. This means that a 1 centimeter clinical margin does not necessarily need to be confirmed by our pathology colleagues under the microscope. But if your dermatopathologist or pathologist reports to you that you had very narrow histologic margins, then you might consider re-excision due to risk of recurrence. Sentinel node biopsy, which will be the subject of my colleague Dr. Angelos' talk, when indicated, this should be performed prior to wide excision of the primary tumor and in the same operative setting whenever that's possible. Otherwise, you can end up with difficult scenarios. For example, this patient had an excisional surgical removal of her primary site with a 2 centimeter surgical margin by someone who was worried that it was melanoma and trying to get ahead of the surgical recommendation. It did show an ulcerated nodular melanoma, 3.4 millimeters in Breslow depth with an elevated mitotic rate. but the patient has not yet had mapping, and you can imagine that when you have a scenario with a surgical wound that's quite extensive, you may very well have interrupted some of the lymphatic drainage underlying that wound, and it will make it much more inaccurate to do the lymph node mapping after. Surgical management of melanoma on a digit requires specialized surgical expertise. Traditionally, distal amputation was recommended. However, digit-sparing surgery may be an alternative, particularly for low-risk lesions. The Japan Clinical Oncology Group has a prospective single-arm study ongoing, and so hopefully we'll have updates on that in the future. So in conclusion, with respect to biopsy, you always want to biopsy with the patient's subsequent care in mind. Remove the entire lesion with a 1 to 3 millimeter margin to a depth sufficient to avoid transecting the lesion. Orient elliptical excisions along the longitudinal axis of extremities. And then if a partial biopsy is needed, repeat the biopsy if the results don't fit the clinical picture, or if you find that you need additional information prior to definitive treatment. Surgical margins remain as they have been for several years based on the Breslow depth of the lesion. They refer to clinical margins rather than histologic. The typical recommended depth is 2 adipose for melanoma in situ and to fascia for invasive melanoma. And stay tuned for MELMART and then a few other studies that my colleagues will discuss as well. Thank you very much.
Thank you, Dr. Todd. Our next speaker is Dr. Douglas Grossman, who's going to speak on prognostic gene expression profiling in cutaneous melanoma.
Thank you, Susan, for inviting me to speak here today. I am going to talk about prognostic gene expression profiling, testing, and sentinel lymph node risk prediction. I'll be discussing 3 commercial products, of which I have no financial interest in. And these are my disclosures. They're not relevant to this presentation. So with respect to melanoma prognostics, we have a very good prognostic system based on conventional staging, based on over 40,000 patients and key pathologic variables, depth, ulceration, node status, presence of microsatellites. And based on this, we can predict pretty well who's going to recur and what their survival is going to be. But the staging isn't perfect. There are patients who fall through. We know that a small percent of early stage patients will ultimately develop metastases, and because these early stage melanomas are so common, they end up accounting for a large proportion of melanoma deaths. We know that adjuvant therapy has been approved in certain scenarios and has been shown to reduce recurrence risk, but how many patients actually benefit from that compared to those who suffer major adverse events. And then with respect to sentinel lymph node biopsy, as a staging procedure, about 80% of those procedures are negative. And looking at negative patients, some of those ultimately do suffer relapse, and some patients who have a positive node actually do quite well. So really there would be value in developing a molecular test to try to improve the staging accuracy and potentially inform decisions on performing sentinel node biopsy, also to inform frequency of imaging and benefit from adjuvant therapy. So prognostic GEP profiling basically is looking at gene expression in the primary tumor to try to predict the biologic behavior. Ultimately, to try to tease out if there's a subset of tumors that might be more aggressive and could require a benefit from a more aggressive treatment, and others that may not need as aggressive treatment. The way this is done is so after the biopsy is done, the tissue is in formalin-fixed, paraffin-embedded block. Sections are cut onto slides, and then from the tissue, RNA is isolated and then subjected to quantitative reverse transcription PCR, looking at expression of a finite panel of genes that have been validated, and based on expression of this limited panel validated genes, the tumor is categorized either low risk or high risk. And the 3 tests we'll be talking about, DecisionDx Melanoma, or the 31 GEP test from Castle Biosciences, the Melogenics test, which is an 11-gene test developed and used in Europe, and then the Merlin test based on 8 genes from Skyline. So starting with the 31 GEP test, this looks at 28 different genes that have been associated with melanoma metastasis, and the 3 control genes. And this is just from the company website. Last year, 2025, over 39,000 tests done. These are on invasive melanomas. Based on invasive melanoma incidence, this translates to about a third of invasive melanomas in the US were tested last year. This is Medicare reimbursable, just over $7,000 is the cost. And last summer, this test received FDA breakthrough device designation. In its initial iteration, the test reported out either low risk or high risk, class 1 or class 2, and then subsequently subsets of those classes. So class 1A is the lowest risk. Those patients had the best or lowest risk of recurrence, and then class 2B had the highest risk of recurrence and poorest survival. And then more recently, several clinical pathologic factors, namely Breslow depth, ulceration, mitosis, and age, were integrated into the algorithm with the gene expression results to produce an integrated 31 gene risk of recurrence result. And from this one study, you can see they're looking at a subset of sentinel node negative patients. The test was able to identify some that had lower risk and actually did a little bit better, and then a group of patients who did worse than the general group. Then more recently, the test also reports out a integrated risk of sentinel node positivity with a low risk corresponding to a less than 5% risk. The other test that we'll focus on today is the Merlin test. This was developed in the Netherlands. It looks at 8 genes, and in addition to those expression of those 8 genes, incorporates 2 clinical pathologic factors, age and Breslow depth. This is designed to predict sentinel node positivity, and in the discovery cohort of over 700 patients who were undergoing sentinel lymph node biopsy, this was developed and validated. Subsequently, the test has also been looked at as a potential prognostic test, and in this study, over 500 patients with negative sentinel lymph node biopsy studied here, and then a subset of those looking at applying the test and that were high risk and had a very high predictive value there. And they were able to capture a significant number of those patients who did relapse. This test is also Medicare reimbursable, just over $3,000, approval in Europe. Commercially available here, but generally has not to date been widely used. We'll come back to that. There are a number of studies, now jumping back to the 31 GEP test, that have looked at how this test could influence decision making. And so this was one study in which they looked at over 500 patients whose tumors were tested, and then they investigated to what extent providing the clinician with the result influenced the management in terms of clinical follow-up, lab work, imaging, and in general, about half of patients, the management was affected, and in general, those that had lower risk result translated to lower intensity management, those with higher risk, higher intensity management. And then another study, the DECIDE study, in which looked at patients who were eligible for sentinel node biopsy. They had their tumors tested, and then shared those results and asked the providers if this influenced your recommendation for sentinel node biopsy. And about a third of the cases, it did influence a recommendation for sentinel lymph node biopsy. Over half of them influenced a recommendation to forego the sentinel node biopsy, but the recommendations weren't binding, and still some of those patients got sentinel node anyway. And so the point I would want to make here is that, yes, this has been studied in this context, but effect on decision making is not the same as clinical utility, which I would define as demonstration that there were actually better clinical outcomes in the patients. And there may be, but we just don't know that yet, because we don't have any studies demonstrating improved outcomes based on the use of the test results. So the dilemma with GEP testing really is when you get a result that doesn't match the risk that would be predicted by the conventional AJCC staging. So for instance, a low-risk T1A tumor, the guidelines say just do the excision, but let's say that had a high GEP test result, would you then escalate the intervention, recommend sentinel node biopsy, and maybe even imaging and adjuvant therapy, none of which would be recommended just based on the biopsy alone. And then here an example, a T1B lesion, guidelines say excise, consider sentinel node biopsy, but let's say the GEP test was low risk, would you de-escalate the intervention and maybe not recommend the nodal biopsy? And then a more advanced stage patient where adjuvant therapy after treatment and imaging would be recommended, but let's say it had a low risk result, would you then maybe not do some of those things that are recommended in the guidelines? And so the problem is we just don't have studies that would guide us to change management that have shown improved clinical outcomes based on the test results. So it really presents a dilemma when, particularly if you don't order the test and patients refer to you with a test result, then what do you do? Final test I'll talk about is the 11 GEP test, Melogenics. This is based on 8 genes developed in Germany, predominantly used in Europe. You get a low risk or high risk result. It hasn't been as studied as these other tests, but I bring it up really just because it's the only test that's currently being incorporated into a prospective clinical trial looking at outcomes. And so this involves 20 sites in Germany looking at over 300 stage 2 sentinel node negative patients. Those who, so they're all getting the test. Those that are high risk are then being randomized to nivolumab for a year versus placebo. And so this ideally will then give some information on whether more carefully selecting those who might be at even higher risk in this category, there might be a better risk benefit in that group compared to the negative side effects of the adjuvant therapy, might have a greater therapeutic index. And then similarly, you might also get information on the other arm of the study, which are those who test low risk of GEP. Those will just be observed. And so in 5 years, we'll have some idea of how safe it is to monitor those patients with a low risk result who otherwise might have been given adjuvant therapy. So recruitment's been completed, is complete, and the trial should be done in a couple of years. So we look forward to some results there. So now going back to the prognostic tests here, some general recommendations. Prognostic testing is not recommended for T1A lesions, although it appears that that's the majority of lesions that are being tested. There are a couple of studies that have been done looking at T1A lesions. Here's one study, 250 patients, and all of them had the lowest risk result. So we would expect at least a couple % of those patients would be expected to have recurrence long term. So potentially the test missed those. And then in a much larger study using this SEER DecisionX DX database, 3,500 patients that looking at those that were had a class 1 low risk result, that was a result in 96%. So it's possible that the other 4%, the test identified as being higher risk, although we don't know yet if those are the patients that actually recur. So this is the problem, so that, in other words, the test may identify those at increased recurrence risk, but as I already mentioned, we don't really know how to manage those patients. But then there's also the risk of the false negative reassurance that you would give to those patients who have a negative result, but we know a small % of those are going to recur. And then the false positive test, you might be causing unnecessary anxiety in patients or promoting interventions that might actually not be necessary. So what do the guidelines state? Because of low probability metastasis in stage 1A lesions, high proportion of false positive tests state that GEP testing should not guide clinical decision making in this subgroup. So now we're going to shift gears a little bit. So I've been talking about prognostic testing, looking at risk of recurrence, ultimately survival, to now using GEP testing for predicting sentinel node positivity. So I'll call this predictive testing. And so, as was mentioned in the introduction, the role of sentinel node testing and the guidelines state that less than 5% risk, which I guess isn't, not sure exactly where this came from, but maybe for any medical test, if the chance of it being positive is less than 5%, maybe it's not worth doing. 5 to 10% risk, consider and recommend greater than 10% risk. As I mentioned earlier, less than 20% of sentinel nodes are positive. How do we avoid the procedure in the other 80%? But there are a number of unknowns. We don't really know yet the impact of missing the sentinel node or of delaying adjuvant therapy if that biopsy wasn't done until they recur and then doing neoadjuvant. We haven't been able to compare those types of cohorts of patients, so we don't really know that information. But the idea here is, there is a clinical need to try to increase the precision, reduce the number of unnecessary biopsies. And so I'll just talk about the two tests, the 31 GEP and the Merlin test that I've already introduced you to. And again, the 31 GEP test gives you a low risk, high risk result, but then more recently will actually give you, with this integrated algorithm, will actually give you a percent risk of positivity. The Merlin test, initially higher low risk, but I understand more recently they'll actually give you a percent risk as well. And so a number of studies have been done on the 31 GEP test. And I'm not going to go through these, but just to point out, a number of them have been prospective. Interpretation of these is limited by several facts. A number of the studies have very few patients. Some have used overlapping cohorts. And I think also importantly, we don't know the actual sentinel node positivity rate or the rate in those with a low risk result in all the studies, because not all the patients got sentinel node biopsies. So that's kind of an unknown. But nevertheless, across all these studies, the negative predictive value, so how confident are you that the node is going to be negative if the test is negative, was quite high. With respect to the CP-GEP test or the Merlin test, not as many studies, but also fairly high negative predictive values. And then really focusing on the last column there, this is the large prospective study that will be discussed later, in which 1,700 patients were studied, large number of patients predicted to be low risk, and this was the result that they got. And so this was the Merlin 001 trial, and Dr. Angelis, we're fortunate to have a surgical oncologist with us today. She's going to talk about this trial and how it's really going to affect her practice. But the bottom line result is in the predicted low risk group, about 7%. So we were hoping it would be less than 5, but a little bit higher than that, had positive result, 93% negative predicted value. And these patients are going to continue to be followed, and so we'll have some idea of how well the test predicts outcomes. So there's the $7,000 test, there's the $3,200 test, there's also free tests, and these are the nomograms, or the sentinel node predictor tools. And so the first one from Memorial Sloan Kettering, there are various clinical pathologic variables you can see there. You just go to the website, you plug in the information, and it'll give you a predicted risk of sentinel node positivity. The other from Melanoma Institute of Australia, also involving age and depth, but then a little bit different in terms of the other factors. And you can plug that in and get an answer. How good are these? These have been studied in multiple publications. This may be one of the largest ones, looking at the National Cancer Database, over 60,000 patients. 15% were sentinel node positive, so comparable to maybe what we would see in most practices. They found that in this study that the MIA nomogram accurately predicted low risk, but may have overestimated high risk. And then several single institution studies looking at these. They both found that the models underestimated the sentinel node risk, particularly in the lower risk patients. And then there's one study with the I-31 GEP test. Maybe it slightly outperformed the MSK model. And then after the initial study with the CP-GEP test was done, they went back and plugged all that information into both nomograms and reported that they felt that their test was slightly better. Subsequent study looks like maybe it wasn't quite as good as the MIA test. More recently, looking at just T1A patients who did undergo sentinel node because of high-risk features, very low overall sentinel node positivity rate, but it looked like the CP-GEP test was able to tease out some of those that were higher risk. So for low-risk sentinel node prediction, what do the guidelines state? Basically, they don't recommend use of any test in place of that consultation with the surgical oncologist. So as a dermatologist, you shouldn't be performing the test to decide, should we be referring this patient? Shouldn't replace that discussion. With respect to the nomograms, says that they may have some utility, but only at a threshold less than 8%, not that 5% threshold. And then for the Merlin test, in patients where you would avoid the node biopsy if the risk really was less than 10%, not 5%, then it may be appropriate, it may have some value there. So let me just conclude with a couple of thoughts here. I think there is great potential for testing. We'd like to see these tests be useful. And indeed, there's room for improving our prognostics and prediction capacities. But we don't really yet know if they're any better than the free nomograms, at least for sentinel node prediction. And then even if the prognostic test is more accurate than conventional staging, is it going to be a difference enough that would be clinically meaningful and make a real difference in large group of patients? And we still don't really know who are the optimal patients to test. The test may be useful for informing decision on adjuvant therapy and imaging in scenarios that aren't currently advocated in guidelines. And despite the fact that these tests aren't recommended in the guidelines, routine use is actually increasing. But again, we don't really know what interventions are indicated based on the results. We may have improved outcomes, particularly in these scenarios where there's discrepancy between the test result and the staging. But again, we don't have data from prospective trials where patients are randomized based on a test result to show that they're better outcomes. So is one test better than another? We just don't know. Are these molecular tests worth the high cost? We just don't know, and we're not going to know until we can study these multiple tests head-to-head on the same group of tumors and same group of patients, and then compare them. And otherwise, we're not going to really know that. Can low-risk GEP patients be spared nodal biopsy adjuvant therapy? Does increased surveillance, more aggressive therapy, improve outcomes for high-risk patients? We're only going to know that if we can have randomized trials based on GEP test results and then look at outcomes. Feel free, that's it, thank you. Feel free to contact me if you have any questions. And I think I'd better just not take questions now, right?
Thank you so much. Thank you for that comprehensive evaluation of what's a very challenging topic. Our next speaker is Dr. Chris Bajakjian, whom I've had the pleasure of being on the NCCN panel forever, and the AAD. And he's going to speak on Mohs surgery and staged excision and some of the newer data.
Thank you, Dr. Sweater. Thank you all for being here. It's Monday afternoon. I applaud your endurance, so thanks for sticking around. I am tasked to talk about Mohs surgery and staged excision. I'm going to talk a little bit about kind of where we are now, but really mostly look forward, because I think that's where the excitement is in this field. I have no conflicts of interest to disclose. So again, just briefly, where do we stand today? And most of this actually has already been reviewed. So these are the AAD guidelines. The last iteration, as you heard, was already almost 7 years ago. And in those recommendations, we stated that Mohs or staged excision really, could be utilized for melanoma in situ, lentigo malignant type, in areas where tissue sparing is of value. If that is performed in the central debulking specimen, if in the case of Mohs, should be appropriately staged for potentially invasive melanoma. And as also was already stated, a very clear statement, again, this is 2019, that sub 1 centimeter margins really are not recommended because we have no prospective data to support that. So as you heard, and you've seen this reference before as well, this is NCCN, which is updated much more frequently. This is the version that was just published. Very similar things, but a little bit more up to date. So NCCN quite specifically states Mohs is not recommended for the primary treatment of invasive melanoma when standard clinical margins can be obtained. It can be considered selectively, and this is a little bit different than the AAD, for both minimally invasive, so T1A, or melanoma in situ in anatomically constrained sites, as we talked about before, along with other surgical techniques, and there are a variety of them that have comprehensive en face margin control. And again, the statement that the central debulking specimen should be analyzed to evaluate for invasive melanoma. And then two important statements in the NCCN. These also have really not changed, but it's important to realize that with respect to disease-related outcome, there have been no prospective comparisons among the different techniques, none. And there have been lots of RCTs that have been done in the past, and that's where we got all the margin information for that Dr. Chop presented earlier. But those were all performed, using standard wide excision, and the caveats that we also know of that many of them did not include or didn't include very many head and neck and certainly no acromelanomas. But, and this is also from the NCCN statement, a current trial will address this, and we'll be talking about that in just a moment. So just to kind of paint the picture, and everybody in this room knows this because you are a dermatologist, but sometimes it's important to also remind our non-dermatology colleagues of this. Like this is, the spectrum of melanoma, and you know this, right? I mean, most melanomas are diagnosed when they're localized disease. A smaller percentage of patients present with regional disease, and a much smaller percentage yet present with distant disease. As we've heard, multiple times in other sessions as well, lots of melanoma in situ that is increasing, but of those 77% that are localized, half of them are diagnosed as melanoma in situ, and half of them as invasive melanoma. So I don't need to tell you that obviously the morbidity and mortality, goes up as you go up this pyramid. But what is also true is that the level of evidence for the treatments that we use, and this is both true for systemic therapy, but just as much true for surgical therapy, level of evidence goes up as it becomes higher stages. In these lower stages, and that is precisely where we find ourselves. No, there is not that much morbidity and mortality, but there's also really not that much evidence. But it is the base of that pyramid, and it is where the bulk of our patients are diagnosed, and these are the patients that we see the most. So it's just important to keep this in mind. So what are some of these unanswered questions when it comes to the treatment of localized melanomas and how it relates to local recurrence, and in these questions about staged excision and Mohs surgery? This is a question that continues to go on. Our frozen sections that are used for Mohs micrographic surgery, are they indeed non-inferior to paraffin-embedded sections when you're assessing particularly the peripheral margin of melanoma? Is complete en face margin assessment superior to standard bread loafing? We think it is, but we don't have any prospective data to support that. So is it actually better? A question that I'm really not going to be able to address today, but I think one that we all want to know the answer to is, what is the biological significance of however you term this, but in our institution we call it atypical junctional melanocytic hyperplasia, but that is a lot about this margin and what is the significance of that. And again, going back to that point that was made by both in the AAD guidelines, are margins less than 1 centimeter sufficient for invasive melanoma? So when going back to Mohs surgery and stage excision, is there indeed no data on there? Well, there's lots of data out there. You know that there are lots of studies that have been done. But there's a lot of this, right? A lot of systematic reviews, a lot of retrospective cohort analyses. And as I said, none of them are prospective. But what I would hope, and these were some of the things that struck me as these papers came out, and these are relatively recent, kind of over the last few years. The title on the top left says, improved overall survival of melanoma head and neck with Mohs versus wide excision. And the other one, enhanced disease-specific survival in lentigo maligna for patients treated with Mohs surgery. That should make all of us kind of pause for a moment. We all know, and we heard Dr. Cha eloquently say that, we know that a 5-centimeter margin for high-risk melanomas did not cause a survival benefit, which is why we stopped doing it. And yet, a surgical technique that is treating low-risk lentigo maligna has a survival benefit. It's odd, right? That alone should really make us think. But if you look at the data that is in many of these studies, there's just clear, the blue line is Mohs, the red line is wide excision, and there's a disease-specific survival benefit. So something else must be going on, and then you look, closer at these groups, and again, these are all kind of retrospective reviews. Turns out, in this particular study, that in the wide excision arm, 5% of patients had regional disease, and less than 1% in the Mohs arm had regional disease. Almost a third of patients had Breslow thickness of greater than 1 millimeter in the wide excision arm, and 6.2% in the Mohs arm. So clearly we're comparing apples to watermelons. This is not the same. And the same is true for staged excision. At our institution, we don't do Mohs for melanoma, we do staged excisions. And you look at the data that is there. First of all, it looks like the menu of an Italian restaurant. There's like linguine and spaghetti and all of that. But it's the same problem. It's all retrospective, and that includes our own data, case series, observational cohort studies, small data sets. So you cannot compare, the results of these studies to the RCTs that were done in the past on invasive melanoma. So 7 years ago, I think now, it's 2026, 2019, this group of people, 2 of them are up here on the stage, we say, okay, we're going to do this. Like we're just going to do this prospective trial and compare, comprehensive margin control versus wide excision. Like somebody has to do it. We're going to do this trial. And I just want to point out the person in the middle, Dr. Wesley Yu. He's at OHSU in Portland, Oregon, who really has been at the forefront of this and has pulled all of us along in this effort. So one of the first things that Wesley actually correctly pointed out, what we need to do if we're going to even try to compare whether it's Mohs or staged excision to wide excision, we're going to have some parameters, and like because everybody knows, everybody who's doing Mohs for melanoma, and whether you're doing linguine or spaghetti, everybody's kind of doing other things. So we did a modified Delphi study and actually got reasonable consensus on if we're going to do this, how are we going to be doing this, and how can we so that we're comparing apples, at least like Granny Smith to Honeycrisp, and there's at least apples. So this was the first trial design that we came up with and called it the cake trial at the time. And the only reason I'm bringing this up is just so that you kind of see some of the history of this, which was essentially just that. So we're going to randomize patients with early stage melanoma to Mohs or staged excision versus standard excision. relatively straightforward, really tried to answer the question that we had. And this was brought forward to SWOG, the Southwest Oncology Group, was approved. We got, an official, SWOG number. And then the next step was, okay, how are we going to fund this study? So we went to NCI and CTEP and kind of ran into a wall and got the message back that the reviewers did not appreciate the importance of this topic and questioned the willingness of surgeons to participate in this trial. In other words, they're saying, are you going to be able to identify surgeons who are going to be willing to randomize patients to a staged excision, whether it's Mohs or with permanent sections versus wide excision? And we had a whole bunch of people who were willing to do that, and yet we were told we were not going to have enough surgeons to do that. So it was declined. We didn't get funding from NCI, even though SWOG approved the trial. So we, I use the term we broadly. Wesley really kind of did many of this, tried other funding, Melanoma Research Alliance, even tried for a PCORI grant. Anybody who's ever worked on a PCORI grant knows that it is an enormous undertaking, which Wesley did. And it was supportive, but it was not funded at the end. So it is funded now, and this trial actually has started, and that's what I really want to talk about for the rest of the time. The term Iceman was coined before the current time when this means something different. That was not the intent. Wesley was truly thinking of Iceman from Top Gun. I don't know why he named the trial this way, but it's called the Iceman trial. It has nothing to do with the current ICE reference. So intelligent choice of excision margin. So essentially what it is it is a multi-site randomized study comparing two surgical interventions, so, and I'll show you those in a moment, for early stage melanoma. T1A high risk, you've seen that now many times, so it's not all T1As, it's the T1As that are considered high risk, T1B and T2A. And those patients are being randomized to either narrow excision, with or without en face margin control, I'll get into that in a little bit more detail, versus standard wide excision. What is different in Iceman versus the CAKE trial is that we have now actually included the result of the Merlin CPGP test in there, which gives us essentially an added data point, which I'll show you in just a moment. So it is patients with these low-risk melanomas who have a low-risk Merlin test who will be enrolled in this trial. Dr. Angels is going to talk in much more detail about the Merlin test. You already heard it from Dr. Grossman a little bit earlier. But this is the paper that was recently published. So it's this category of people that we're talking about, T1A, T1B, and T2A. And the number 7.1% has been mentioned several times as the risk of sentinel node positivity in those groups. But actually, if you look at the subgroup analyses, it's smaller in those specific groups. So in other words, these are patients with a low risk of sentinel node positivity. So they undergo the Merlin test. Merlin is low risk, and they're then randomized. That was a little too quick. They're then randomized to, as I said, either narrow excision with nodal observation or wide excision and nodal observation. So in a little bit more detail, so as I said, they first undergo Merlin test. It's low risk. If the Merlin test comes back as high risk, then they just go to standard of care. They undergo wide excision and likely sentinel lymph node biopsy. But so if it is low risk and it is in these categories, as I said, they are then randomized into these two groups. And so just to provide a little bit more detail, if they're randomized to wide excision, it is wide excision. Standard NCCN margins, that's it. If they are randomized to narrow excision, then the treatment depends on where it is as far as anatomical site is concerned. So if it is above the clavicle, essentially, if it is head and neck, then they are treated with one of the comprehensive margin control methods, whether it's Mohs or whether it's linguini or spaghetti or any of the en face margin controls. But if it is below the clavicles and it's not a place where we would typically do these staged excisions, they're treated with a narrow excision, and that is a excision with a 5 millimeter margin, so a half centimeter margin. And that is really probably the part of the trial that I'm actually most excited about, because I think many of us have for a long time thought that many of these low-risk melanomas can be excised with a smaller than 1 centimeter margin, but we, as I said, have never had a trial to this. So what are the endpoints of the study? The primary endpoints is 3-year local recurrence free survival in this group. That is really what we're focusing on, is local recurrence. Secondary endpoints, 3 and 5-year regional disease-free survival, the 5-year local recurrence-free survival, melanoma-specific survival as well. Also quality of life, and that's an important part of this, especially as we're doing different surgical techniques, and you can imagine how there are different experiences with all of those and the surgical complication rate. So really, at the end of the day, this trial should answer, 3, I think, really important questions. So it is the first randomized controlled trial comparing standard excision versus complete margin control, as I've said several times now. But it also is comparing wide versus narrow excision for clinical stage 1 melanoma. We do not have that, and that's going to be very exciting data. But it's also, and that's where the nodal surveillance will be helpful, will have a large cohort of patients who will be, Merlin low risk, and therefore we are following them. It's a little bit more nuanced because they actually could undergo a sentinel lymph node biopsy, but many of them, likely will not undergo a sentinel lymph node biopsy, and will be able to follow those. So Portland OHSU has started recruitment. I think they have recruited their first few patients. We have just about gotten IRB approval at the University of Michigan, and we'll start to enroll patients very soon. Other sites are Stanford, University Hospitals of Cleveland, and Dr. Yu is talking to many other institutions throughout the country who are interested, and so we're hoping to get multiple sites. We need to get to about 1,000 patients. So the study is enrolling, and I hope that in years to come we'll be giving you updates on this. But again, from a surgical perspective, as far as doing randomized trials, this is the first trial like it, and very excited to see what happens. I think I'm within time. I'll leave it at that, and we'll take questions at the end. Thank you.
Thank you, Chris. And I'm going to invite Dr. Michael Tetzlaff from UCSF to talk about pathology assessment and reporting. So we're going back. And Mike, thanks again for switching talks. Whoops, I think something just loaded. That reloaded again. Let me escape. Sorry. Just pushed.
As we're loading, thanks, Susan, as always, for the privilege to be here. I hope everybody can hear me. I'm a little taller than the microphone. And that was a tough act to follow. I always have to tell Chris after how much I enjoy his talks, but I just thought it was really fantastic and thoughtful, so thank you for those remarks. I will go backwards in time and talk to you about how we, as your fair country pathologists, arrive at the diagnosis of melanoma and what are the tools in the toolbox. And then once we have that diagnosis, of course, how do we report and stage the disease? This will be subject to change as we embark with AJCC 9. I do have disclosures, none of which are relevant to my remarks today. So the tools in the toolbox, obviously histopathology is our first tool, often our only. We use some immunohistochemical studies, and they'll talk about molecular studies. And then we'll talk about how we report the disease, and we'll sort of motor through this quickly. I do think these guidelines are still really important to consider for the dermatologists in the room, to consider not just providing us with essential information like age of patient, et cetera, but also size of the lesion, your clinical impression, and performing a biopsy that captures the entire lesion so that we are able to evaluate things like symmetry and circumscription, which are really important variables in terms of arriving at a diagnosis. So thankfully, in our current climate, this is actually my worldview. This is kind of how I think about life in general, and that is that melanoma arises through a progressive accumulation of alterations in its genome. And as a pathologist, what I'm actually looking for is histopathologic features that correlate with that progressive alteration, and in some cases, also obviously immunohistochemical and molecular surrogates of that. But what we're trying to do as pathologists is to position a lesion along this spectrum and render the appropriate diagnosis that then delineates that patient for appropriate care. So in most cases, we can look at the top lesion and say this is an unambiguous nevus, whereas the bottom lesion is an unambiguous invasive melanoma. We don't need additional studies to make that diagnosis. In other contexts, and obviously there's a lot more here than I'm going to talk about today, but there are context-dependent immunos in addition to specific biologically informative immunohistochemical studies and molecular studies that inform that diagnosis. So how can immunostains facilitate the distinction of melanoma from nevus? This is a nice example of an unambiguous melanoma arising in association with an underlying nevus. You can sort of see the distinctive morphology of the melanoma from the underlying very quiescent nevus. You can appreciate the cytologic differences between the melanoma cells and the underlying nevus. What are some of the immunohistochemical stains that we can do that will inform the biological differences between these two populations of cells? One that's very useful, not super sensitive, but is very informative when we see loss of P16 as a surrogate for the integrity of the 9p21 CDKN2A locus. This raises consideration for melanoma. You can see in the top part of the lesion where there's melanoma, it's lost. The bottom part of the lesion where there's nevus, it's preserved. Ki67 is a marker of proliferation. We look for an elevated proliferation index as a surrogate of a more biologically aggressive lesion. That's more typical in melanoma, whereas the underlying nevus, you can see almost absent proliferation. There are exceptions like pregnancy and trauma, but in general, this is a fairly robust test. And then, of course, we come to PRAME. PRAME has been shown in a series of studies. I'm just going to cite Klaus's work, where it's generally positive, and positive is defined as 75% of the melanocytic nuclei showing 4+ positivity. Generally, it's positive in melanoma. Generally, it's negative in nevus. Obviously, we've all, as dermatopathologists, had examples of PRAME-negative melanomas and PRAME-positive nevi, so really important to correlate with all of the features. This is a case of unambiguous melanoma to just sort of prove to you that, yes, in many instances, PRAME is positive in melanoma. I think PRAME has some good utility in certain other instances. I think it's helpful for microstaging when you have melanoma and nevus and you want to provide an accurate Breslow thickness, assuming it's a PRAME-positive melanoma. I think it can also be useful as a tool for margin assessment, again, in some melanoma in situ excisions when it's a PRAME-positive MIS and you're sort of assessing the distinction of melanocytic hyperplasia and bona fide lesion. So it has a lot of utility, but it's not a standalone test. I won't spend time talking about this. There is a gene expression signature that purportedly differentiates benign nevi from melanoma. The three components of this mRNA assay, which we saw the parameters for, or how it's done earlier, include PRAME, S100 family of genes, and a broad component of immune markers. The relative expression levels of these three features through a proprietary assay generates a score that facilitates, in some instances, the distinction of melanoma from nevi. But I have to say this is not a test that I use, and it's not a test that I'm terribly familiar with its operating characteristics in sort of real practice. I think what is really helpful is seminal work from Boris Bastian, Phil LeBlanc, and our group at UCSF. This dates back to 2003, and what they basically showed us in this study is that melanomas are typified by gains and losses in regions of the chromosome that you don't see in nevi. And so through a large series of melanomas, they showed us that the genome of melanoma actually has gains and losses in regions of the chromosome, and you could leverage that difference to inform your diagnosis. And that's the basis for the FISH assay. The FISH assay takes a snapshot of the genome. You're looking at discrete loci, looking for the relative copy number of those fluorescent signals. Obviously, in a diploid genome, you would have one copy of each from mom and dad. In a melanoma where you have gains and losses, what you would expect to see is increases or decreases, relatively speaking, in the number of those signals in a given cell. If you hit a certain threshold of percentages, that's a positive result. This is good when you have rate-limiting or cell-limiting small cellularity lesions to interrogate further. Obviously, nowadays we have a whole genome comparative genomic hybridization through array, CGH. We also have the same data. This is an example of a next-gen sequencing assay that shows us relative gains here and losses in the genome of a melanoma, whereas we see a flat line in the NGS result for nevi. This is obviously, I think, a very important and seminal study in our field, again, led by Boris with Hunter Shane and Iwei Ye from our group at UCSF and a whole host of other pathologists and clinicians there. The upshot of what this story showed us is exactly the slide that I presented at the very beginning of the talk, and that is that melanoma arises through progressive insults in the genome. So if you look at just benign nevus, you see a single MAP kinase activating event. As you progress histopathologically, you see a progressive accumulation of genomic insults that culminates in a melanoma phenotype. And so this is kind of the data that we're trying to interrogate, if you will, as a model for our looking at lesions in the clinical setting, and that's kind of our approach. So let's take a quick example to sort of see how this works in real time. This was a case I actually got in consultation, 74-year-old woman. You can sort of see this lesion has mostly a dermal component, a little bit of scarring over the top. So somebody's been here before, but we had no history of that. Not supercellular, but when you come down to the lesion itself, the cells, the melanocytes themselves are quite atypical with hyperchromatic nuclei, a lot of asymmetry with respect to the pigmentation, and these nuclei are quite large and hyperchromatic. So we wanted to work it up further. The P16 has an interesting result in that it's diffusely positive, so that's not really informative in terms of a malignant diagnosis. PRAME is diffusely positive. That's sort of pushing forward towards a melanoma diagnosis. So we have these conflicting criteria. We submit this for UCSF 500 next-gen sequencing. We see a number of abnormalities. So we have our MAP kinase driver in the form of an NRAS mutation. We have CDK4 amplification, which I think correlates with that strong P16 expression. We have a TERP promoter mutation, but in addition to all of those changes, we have a number of different gains and losses in the chromosomal copy number content, together supporting a diagnosis of a melanoma that was, in this case, partially biopsied. So when we have the diagnosis of melanoma, how do we go about staging it? Obviously, this is going to undergo a new iteration coming shortly, but this staging system that we're currently working with, 8th edition, only applies to cutaneous lesions, doesn't apply necessarily to melanomas from other sites. These are the elements that I typically provide in a report. They're elements that are required by the CAP. They're elements that are required for staging by AJCC, and they're elements that are recommended by the AJCC for a prognosis. We just completed work for the American Society of Dermatopathology as a task force, sort of reappraising these elements. I think there's general agreement about what's minimally required, but this was a nice study in the JCP where some of us got together and agreed on what our sort of recommendations were for minimal effectiveness of melanoma reporting. So T category, I think it's been discussed today. We've talked about tumor thickness as the Breslow thickness and ulceration. Mercifully, mitotic figures sort of left the staging realm, but they're still important in prognostic. We measure Breslow thickness from the top of the granular layer, the base of the ulcer, to the deepest point of invasion. We know that this is an extremely robust prognostic indicator. The T categories in melanoma are defined by Breslow thickness. We can go T2, 3, and 4 are basically 1 to 2, 2 to 4, and greater than 4, and you distinguish A and B on the presence or absence of ulceration. T1A, or thin melanomas, are less than 0.8 and non-ulcerated. T1B are between 0.8 and 1 millimeter without ulceration, and basically any ulcerated melanoma less than a millimeter is a T1B. We know ulceration is a histopathologic distinction, so you want absence of epidermis intact with an accompanying host reaction and fibrin deposits with a neutrophilic scale crust. This is, again, a microscopic examination and must be distinguished from artifactual or traumatic disruption. You can sort of see how the T categories segregate, but when you put those into their relative stages for N0 disease, you can see a very robust melanoma-specific survival probability that's sort of produced by that algorithm. Mitotic figures, just to make a point and a plug for them, still important, and this is not a binary variable. They're very prognostically relevant. A number of other features that we look for: specific histopathologic subtypes, lymphovascular invasion, neurotropism. We still report those variables, and they're very important for the prognosis of the patient to still capture. This is a very busy slide that I think is much easier to reproduce in cartoon fashion. Nodal disease we effectively distinguish based on 3 features. Clinically occult, and I know the word occult nowadays has sort of various meanings, and I won't make any jokes at all, but just to let your mind wander with that. Clinically occult or clinically not detectable nodal disease If that's all you have, you're going to be in the A category, depending upon the number of nodes. If you have at least one clinically evident lymph node, you're going to be in the B category, depending upon how many nodes, and then the presence or absence of a microsatellite, satellite, or in-transit metastasis is what pushes you into the C category of disease. And again, you add the numbers of nodes to sort of complement that designation. We look at this in the sentinel node setting. We can see this on H&E, a depositive melanoma in the subcapsular space. We can also detect this by immunohistochemistry, and there's no minimum size threshold required for the designation of metastatic melanoma involving a sentinel lymph node. Can be done by IHC alone. When I report sentinel lymph node disease, I do report not only the location, because we know that this is prognostic, I also report the size of the largest discrete unit. This will inform therapeutic decisions in the adjuvant setting if you cross a certain threshold of size for that deposit. And then we come to the satellites, microsatellites, and transit diseases. These are defined as a separate focus of melanoma that is distinct from the primary melanoma by normal tissue, and they're each considered to represent lymphatic spread of the tumor. There's no minimum size threshold to make this designation. You can see the primary melanoma, you can see normal tissue. This is a microsatellite, which is clinically occult and distinct. So you're only going to really detect this unless you're a savant in the primary resection specimen, because it's defined as a clinically occult lesion. A satellite is clinically evident within 2 centimeters. And in transit is clinically evident beyond 2 centimeters, but still bound by the regional lymph node basin. So you can sort of think about it mechanistically in this way. Microsatellite usually being in the excision, satellites clinically evident within 2 centimeters, in transits greater than 2 centimeters, but still bound by that regional lymph node basin. And this sort of summarizes where we are with our stage 3 prognosis in terms of melanoma-specific survival. This is a combination of the T category and the N category that defines the patient's position in this chart for this stage, and you can sort of see how nicely this delineates melanoma-specific survival. Not a lot of changes in the 8th edition to the M category, so I won't go through that because that's really been impacted by therapeutic interventions, and I think this will be tackled in subsequent episodes. Really grateful to my colleagues at UCSF and MD Anderson, and again for the privilege to be here. Thank you.
And I just want to credit Dr. Tetzlaff for really spearheading the efforts on defining that major pathologic response in the neoadjuvant setting and the nodal setting. So I think it's critical. So thank you so much. And our next speaker is a surgical oncologist from the University of Michigan, Dr. Christina Angeles, and she's going to talk about sentinel lymph node biopsy and the Merlin trial.
Great, thank you. It's really a pleasure to be here and represent surgical oncology. My clinical practice is both melanoma and sarcoma. I run clinical trials. I also have a tumor immunology lab, so the immune system in melanoma is dear to my heart. So one of the things I just want to put out there, as we talk about the standard of care of sentinel lymph node biopsy today, there's a lot that's changing, right, with neoadjuvant therapy and all of that. And so I'm not going to get into that today. We're going to talk about standard of care, what we know, and where we're headed. I was one of the principal investigators at the University of Michigan on the Merlin trial, and I also act as a consultant now that we have data and figure out how to use that data. So in general, what is the sentinel lymph node biopsy, since most of you don't actually do this? So we use typically 2 dyes, both a radioactive tracer and then a blue dye in the operating room where we inject the primary melanoma site. It gets taken up into the lymphatics, and it will drain into the primary drainage lymph nodes or sentinel lymph nodes, okay? So typically that's between 1 to 3 lymph nodes in a basin, but for our patients that have, let's say, a back melanoma, it could map to 4 locations, right? So when we talk to our patients about this, it's not just the primary site wide excision and the sentinel node site. It potentially could go to both axillas and both groins. I have patients like that. It happens, right? About 25% of the time. So you have to, make sure that you know what the morbidity and the risks of going into a sentinel node procedure, because they could step out of your OR with 5 incisions, okay? If it's on the arm or leg, not so much, but if you do this with 2 dyes, you successfully map 98% of the time. when you use both dyes. And the risk of having a negative sentinel lymph node when you do both dyes is less than 5%. So it's actually a really great test to identify the correct sentinel lymph node, and then our pathologist then looks at it and tells if it's positive or negative. And overall, it pretty much is a low morbidity. So this is what it looks like in the operating room. We see that dye, we take that out, we try to stay very close to the lymph node so you're not cutting lymphatics you don't need to, so they don't get things like lymphedema of the extremity. And so current indications, you heard a little bit this, right? But based on NCCNs and guidelines, when you have a T1A that's low risk, right? We do not recommend doing that. That's a low risk. So we don't do GAP, we don't do anything, we don't recommend it. However, for those T1Bs that are 0.8 or more, or less than 0.8 with ulceration, we consider it. And also there's the subsets. They're not officially T1Bs, but the ones that, the young age, less than 42, greater than 2 mitosis, LVI, we consider. Those patients are referred to us and we discuss the risk and benefits of doing the sentinel lymph node because there could be a 5 to 10% risk, okay? Now we talk about this 5 to 10% risk, 5%, what is that based on? For every patient, I can tell you some patients have a 2% risk and they're like, cut me tomorrow and take out the node. And then I have patients that have a 10% risk and they're like, why would you ever consider doing that? That's so low, right? So you have to understand there's a lot of shared decision that we do with our patients when we talk about sentinel lymph nodes. Now, for the intermediate risk, we do recommend for accurate staging because it's estimated there's a greater than 10% risk. I am going to talk about long-term follow-up data from MSLT1, which is where patients were randomized to sentinel lymph node or observation and only to do a complete lymph node dissection for clinical disease, and everyone with a positive sentinel lymph node got a complete dissection. The now 10-year follow-up data shows that there might be a subset of those patients that the sentinel lymph node biopsy is curative, right? And they don't recur less. So we're going to talk about that. So there might be a group of patients that we might want to think about sentinel lymph node biopsy, not just for staging. And then thick melanomas, we stage them with sentinel lymph node, but we are definitely not potentially giving them benefit because they are so high risk anyway. Right? So I can tell you, I trained at Memorial Sloan Kettering Cancer Center, and out of all the surgical oncologists, there were some that would never do a sentinel biopsy for the thick melanomas, and the others that would. And that is a discussion, again, we have with our patient, because are we actually benefiting them? We know they already have a very high risk of distant disease. Overall, there is a low risk of complications, especially in your healthy patients, right? When you have that healthy patient who has no comorbidities, you take them to the operating room, they pretty much have, a low rate. Now, that seroma rate, it depends what you call seroma. Everyone is going to have some fluid under the incision. When you take out a sentinel lymph node, it goes away in 2 weeks. But overall, it is a low-risk procedure. And most of these complications are maybe if they have an infection, you give it antibiotics for a few days, wound care. So there's no real long-term morbidities, and lymphedema is extremely low risk if you do a sentinel lymph node appropriately and stay very close to the lymph node, and you're a surgical oncologist trained doing this, not a general surgeon who does it 3 times a year. Okay, so reasons to do a sentinel biopsy. 1, staging. You just saw this, right? So this is great. This is the best staging we have. You have your T stage and you have your end stage. And, the 8th edition really improved prognostication. But of course, there's some constraints. But, when you look at the sentinel lymph node negative population and you look at the overall survival, the 5 and 10-year survival, and you compare it to the negative and positive, you stratify the patients out significantly. So if you did not do a sentinel lymph node biopsy, right, so you don't know if it's negative or positive, you wouldn't be able to tell this difference, okay? So if you have a patient who has a clinical 2B, and you tell them that their 10-year survival is 82%, and you don't know about their sentinel lymph node, if it was positive, you bring that down to 60%. That's a big difference, right? So this is where sentinel lymph node biopsy helps you educate your patients and think about what their recurrence and survival is, right, relative to their melanoma. But not all stages are the same. So I'm just going to give you a few scenarios. We see these patients all the time, the 3As. We say, 3A patients, oh yeah, they're the best. They're the best 3s, right? These are the 1 millimeter melanomas that might have one small deposit of melanoma in their sentinel lymph node. So here's one example. But this is also a 3A. 1 millimeter has ulceration, 1 positive sentinel lymph node, 9 millimeter deposit though, but that's not in the staging system. I know that patient has a higher risk, right? Now patient 3, 2 millimeter, sentinel lymph node positive, 3 positive sentinel lymph nodes, still 3A, right? So we just know by looking at this, I know that these patients are not the same, but they're staged the same. So this is where maybe looking at the pathology of the node, or maybe where gene expression could be helpful and complementary in the future. We just don't have the data yet. Now this is a very interesting study. This is 3,600 patients where they looked at the size of the sentinel lymph node deposit, right, the micrometastasis, and it's stratified out between less than 0.3 and greater than 0.3. They also looked at 1 millimeter, 2 millimeter. Once you get above 0.3, it doesn't make a difference. It stratifies like this, and there's a significant difference in 5-year and 10-year survival. So this is something we consider when we think about stage 3A patients. Okay, so now we're going to talk about may a sentinel lymph node improve survival? So the MSLT1 trial, so this is way back, right? 2006, right? Where we have the trial. And this is the first where we wanted to, when I say we, I wasn't doing it yet, but it was, do we even do a sentinel lymph node? What's the utility of it? And patients were randomized to sentinel lymph node. If it was positive, they got a complete dissection. Or we just watched the patients, and if they had a clinical node recurrence, then they got a dissection, okay? And what this showed, the early data, is that we were finding the same patients. We were identifying the same amount of patients that would have a clinical node develop with the sentinel lymph node biopsy. So we were identifying it earlier. So great, it works. No difference in melanoma-specific survival at the early report of this, and this established the role of sentinel lymph node biopsy. Well, in 2014, the long-term follow-up data was looked at, the melanoma-specific survival. And if you look at the patients who had a sentinel lymph node that was positive versus the patients who had node recurrence and underwent lymph node dissection at that point, remember, all of these patients got lymph node dissection, right, which we don't do today, you can see that there is a significant survival difference at 10 years. So, right, 41 versus 62 alive at 10 years. And so there is a difference there. And this is only for the intermediate thickness melanomas, which at the time was defined at 0.2 to 3.5. When you look at the same long-term follow-up data from thick melanomas, the greater than 3.5, there is no difference, okay? So again, saying that sentinel lymph node biopsy definitely doesn't have a utility in this setting, and there could be a potential role, right? The patients that may be doing that sentinel lymph node and picking it up early before it kind of got out of the node. We can talk about immune surveillance, but there is something here that I think we should consider. Okay. It also informs the method of surveillance. So when we have a patient who does a sentinel lymph node, we now know how to follow them. So MSLT2 was where patients who had a positive sentinel lymph node were randomized to either observation with ultrasound. So we do this every 4 months for 2 years. If it's still negative, then we do every 6 months for 3 to 5 years, versus patients got a complete nodal dissection. And the reason why this was done, this clinical trials, because as surgeons, we know that like 85% of our patients had lymph node dissections with negative nodes. We were taking out so many negative nodes that were like, there has to be a better way. So is there equipoise in not taking out the nodes right away? And the best way to identify this is with ultrasound, right? If you have a good ultrasonographer and radiologist, we can pick up these subtle findings, rounding of nodes, different echogenicity of the lymph node, and we can identify changes before you see it on a CT scan or a PET scan. PET scans are negative, right, in this setting, but you can pick up this on ultrasound. In this trial, if there was a change, then it got biopsied, it was positive, then the patients had complete nodal dissection. And what we saw is that the node recurrence-free survival, of course, was different, right? We know 15% of patients do have positive disease there, right? And we identified that and then took them for dissection. But there was no difference in melanoma-specific survival. So now we're saving 85% of patients, right? And we're not taking them all to the operating room. So this was great. So now we can do that. However, if we didn't do the sentinel lymph node, we wouldn't be able to do those ultrasounds and pick them up because we don't do it on the sentinel lymph node negative patients. So how would we know which patients to monitor if we didn't do a sentinel node? In all the trials that we're talking about, right, we're in the setting of doing a sentinel lymph node biopsy. And we're also going to think about when we talk about adjuvant trials, and the next talk is going to really dive into that. All of those patients had a sentinel lymph node biopsy so we could, right, correctly stage them. And so if we're going to use that data to interpret how to treat our patients, right, it is a very important piece of data. I'm going to step back, though, and say, are we doing too many sentinel lymph nodes, okay? So 85% of patients that we do sentinel nodes have a negative, right? So now here we're going back to those numbers again. We're like the majority of patients that we do sentinel lymph node, it's negative. So we accurately stage them, but, you know, is there a way that we could identify better which patients have the risk? And, you know, we use age, thickness, mitotic rate. You saw those nomograms. All of those help us kind of make decisions, but I can tell you it's really hard to know and also to tell a patient that there may or may not be, you know, what's their specific risk. And I can tell you for a patient, it's 100%, right, if it's positive or negative. So these are long discussions we have. And then there's the patients that have the T1As. We talked about their very low risk. We don't do a sentinel node biopsy, but there are patients that have a higher than 5% risk, you know, and who are they and how do we do? And you heard about the gene expression. So we're trying to get data. We need the tools to be able to do that. I'm going to use a case example to now kind of talk about these nuances of adjuvant therapy and, you know, how we think about developing a way to think about patients, whether we should do sentinel node or not. This is one of my patients who came to me. She was 44. She originally had a 0.4 millimeter superficial spreading left shoulder. It wasn't ulcerated. There was 2 mitoses. She was treated at another hospital in the community. There was a deep margin on shave. They actually did microstaging. It came back at 0.5, and so she had a wide excision with 1 centimeter margins. At 18 months is when I met her. She noticed a palpable mass in her left axilla. It was metastatic melanoma. She came to see me. We scanned her. You can see she has a large node right there, and they actually put a clip in it thinking that maybe we could treat her. She had other staging, negative for any disease. So this is oligometastatic in her lymph node stage 3, right? So resectable stage 3. And today, after we had S1801, standard of care is to have neoadjuvant immunotherapy before doing dissection. Surgeons did dissections for clinical nodal disease for decades, and we don't cure patients, right? With neoadjuvant therapy, we see better outcomes. However, she had an autoimmune condition, had chronic pericarditis, and the risk was just too high. So the medical oncologist said, you know what, I think we treat her surgically. She's young. We don't want to hurt her with her disease. So if we just think back to this, if we knew that she was the high risk stage 1, right, the 0.5, if we knew that, and, you know, at that time, if we did a sentinel lymph node biopsy, she would have been 3A. Her 5 and 10-year survival, right, is 93-80%. Adjuvant therapy is actually not recommended in this in NCCN guidelines. And, you know, could that have been a better outcome? If you think about the adjuvant trial here, pembrolizumab versus placebo, this is all stage 3 here. I'm sorry, no, I pulled out. This is just the 3A. There's no difference in survival in the early data. So this is the median follow-up, only 1.25 years. With longer follow-up, would this be better? We actually have that now. Now remember, if anyone recurred, they could cross over. And so here's the long-term follow-up data just came out in 2024. So if you look at the 3A, there's no difference, right? So adjuvant immunotherapy is not helping these 3A patients. For 3B and 3C, there looks like there can be improvement in recurrence-free survival, right? We're not talking about overall survival or melanoma-specific survival. We're talking about recurrence. And a lot of times we think we just delay recurrence sometimes in adjuvant therapy. But in any case, in 3A, she wouldn't be recommended this. And when we think about patients, if we don't do a sentinel node biopsy and they recur, everyone's like, well, maybe we can just give adjuvant therapy. Well, there's a lot of risks. A lot of young women become infertile. They have other issues, autoimmune conditions, and all patients will get some kind of side effects, but not all of them get the benefit. And so when we think about patients, we have to really think about the risk and benefits, and I think we have to be careful about altering our standard of care without the evidence showing that that is safe to do. When we look at the NCCN guidelines for stage 3, in terms of adjuvant therapy, with the patients with very low tumor volume, stage 3A, right? The toxicity outweighs the benefits, so it's not recommended. But they did add that study I showed you. So if you have a 0.3 millimeter or more metastasis, maybe we consider it because we know that the outcomes, right, are worse here. So it's something to think about. And also maybe those ones that have less than 0.3 and really have a great 5-year melanoma-specific survival, maybe we don't have to be PET scanning them every 6 months or every year, and we can think about that a little bit more closely. However, we know those patients also have the risk of nodal recurrence, so we do ultrasound them still, right? And that is a low-risk, low-cost way to survey our patients. So, when we think about using gene expression, can that predict the sentinel lymph node involvement in high-risk disease? In my patient that I just said, if it was performed, could have that prevented macroscopic nodal disease? Potentially, but we don't know. The MSLT1 data I showed you didn't test in melanoma, so we don't know if that would be the case in this case. But this, again, is a good example where we do need prospective data for a gene expression profile to help us do this, to decide when to do a sentinel lymph node biopsy in maybe the higher risk patients. So this patient, just to kind of close the loop, I did a complete nodal dissection. She had extensive disease, 5 out of 19 lymph nodes. There was extranodal extension. So she ended up with stage 3C melanoma. And we're currently just watching her because they don't want to give her immunotherapy right now, but the risk-benefit changes if she does recur. So in any case, I think we need to think about, in the setting of stage 3 adjuvant therapy, there is that benefit, but only 1/5 of patients actually benefit, right? So if you look at, this is all comers stage 3, 43% don't recur naturally. Their own immune system works, or maybe the disease hasn't progressed, right? And then you have the percent that does recur, that you're improving the recurrence-free survival. So only 1/5 of patients benefit. So, and we can't now predict who will benefit. So this is another plug of using gene expression in our clinical trials so that we can actually see if we can predict this. Because I think doing retrospective, it's not as good, and we have to include gene expression in our clinical trial design. Sentinel lymph node biopsies were also required for inclusion to the adjuvant trials with stage 2 melanoma, right? So this is all after sentinel lymph node biopsy, so something to think about. And why do a sentinel node biopsy in the setting of adjuvant therapy? So I'm going to take you through a little math here. 30% of our T3B, T4 patients will have a positive sentinel lymph node, right? So 6 out of your 20 patient population, just to give you something to look at. Adjuvant therapy decreases nodal recurrence by 30%. So if you don't do the sentinel lymph node biopsy, then you end up with about 20% of patients that require a complete lymph node dissection. In the setting where I'm saying if you know they would have a sentinel node biopsy, based on MSLT1, we know eventually they will get clinical nodal disease. Now, if we do the sentinel node biopsy, right, about 5% after a sentinel node biopsy will have an in-basin recurrence, even if they had a negative sentinel lymph node. The real number is somewhere around 3%. It depends on what data you use. 15% have that in-basin recurrence after a positive, because we don't do complete dissection anymore. And so if you gave adjuvant therapy to these patients, you only have 5% that will actually require a complete lymph node dissection. Now, I'm not going to get into the whole discussion about, do we do complete lymph node dissections in the setting of neoadjuvant therapy? There's 2 clinical trials going on right now, another one that's going to open up soon. We might not have to do dissection. We might do neoadjuvant therapy, single node, but we don't have enough data to make it standard of care yet. But there's 3 trials. We have 1 open at our institution right now. But again, in the current setting, you might end up doing more complete dissections if you don't do a sentinel node. Okay. Patient selection for sentinel lymph node. If you want to think about a lot of patients don't have therapeutic benefit, can we predict? This is going to get into the Merlin trial. So you heard, I'm not going to get into many details. You heard about the design, but the thing that I want to point out is, the nice thing about being one of the investigators in the trials, I actually get to talk to the scientists, right, who kind of developed this and how they're thinking about it. And they did a lot of testing of just the gene expression with and without the pathologic clinical data, and this really worked the best. But I have to tell you, if you're going to add the thickness, we have decades of data to know if you have a thick melanoma, your risk is higher. So, the idea that you're going to get all comers in a trial in less than 5% is an interesting thought, but that was what they set, right? Their goal is, can we get less than 5%? And just to know, right, so this is the eligibility criteria. So we did not do T4s, okay, into this. And in order to be a T1A, you had to have a high risk. You had to be less than 40, greater than 2 mitoses, and lymphovascular invasion. That ended up with only 26 patients, okay, out of the 1,700. So we're not going to think about that data. We don't have enough patients to really say anything about that. But it was a successful test. At Michigan, 720 of those patients came from Michigan. I saw the data, I oversaw it. So it's really robust data. And when you look at all comers, right? It's about a 7% when you put all of those T1 to T3s. I can tell you if I have a patient who has a 3 millimeter melanoma, I'm going to do a sentinel node biopsy. I don't care what a gene expression test is, right? If you talk to most surgeons. So looking at this data, as a surgeon, the all comers, it doesn't matter. For me, it's going to be the subset. So I'm going to show you one thing that I want to bring up. And the reason why this is in here after wide excision, one of the things that we do at Michigan a lot, if I have a patient, right, who has a melanoma and has a positive, like a transected base, and I have to make decisions on that for a patient, we will microstage. And this is very important for this test, right? One of the things in the algorithm is the thickness. So if you have a 1 millimeter transected base and you put 1 millimeter into the algorithm, but the patient actually has a 2 millimeter melanoma, that's going to change the outcome. So we pushed to look at the wide excision, the real depth, to see if that changed the algorithm, and it did, okay? So in all comers, not a ton, right? 7.1 or 6.6, but if you want to try to get under a certain number, it does make sense. So if I'm going to use a Merlin test, I make sure that I know the absolute depth, so I ask my dermatologist to do a microstage. So this is the key patients, right? The ones where you're going to think about, do I do, the consider, the 5 to 10% consider. I spend a lot of time with those patients. It's very easy to tell a patient with a 2.5 millimeter melanoma, we're going to do sentinel node. That's what I recommend. It's very easy for the ones that are right. But this is the group. It takes a long time to have these shared decisions. If you look at the T1Bs, and especially if you have the correct thickness, a low-risk test is 4.6%, right? You're below your 5%. So this is like a win if it's going to make a difference. Now, if I talk to a patient and they want a sentinel lymph node, then we're going to do a sentinel lymph node if they fall into that, right? But if there's the patients that either don't want to go to the operating room or they have morbidities, this would be a nice utility. For the T2As, it's going to be about 8%. And for some patients, less than 8% makes sense. You have to decide that with your patient. I do want to say for head and neck melanoma, we had 284 patients. It works really well. So this is all comers. This isn't just a certain stage. When you look at all head and neck melanomas, you can get below the 5%. And patients older than 65, you're at 6.6% for the low risk. The design of this was to say who not to do, right? Forgo sentinel lymph node biopsy. So we're not talking about high risk. We're talking about that. So let me just quickly, do I have time for patients? No?
You've got to get to Henson's talk.
Okay.
I think, are you over 20? I think you're
I don't have a... Okay. All right. So just really quick. So here's an example, right? Memorial MIA, we're at 12 and 10. You can see that you would be above 10%. This patient came back as an 8%, just to give you an idea. And it also can work the other way around, where I had high-risk patients where they go to the OR. So I have a lot of different things. I just want to tell you, this is the exciting thing. We can't talk about prognosis right now, but we're going to have long-term follow-up data that's really exciting, including all the adjuvant therapy patients. Okay, I'm going to just leave that there.
Okay. And you're here to answer
Yes,
questions.
I can
and
answer
maybe we
questions,
put these
yeah.
up. I just want to be respectful of Henson's time, too. And thank you so much, Christine. Great data. So my pleasure to introduce Dr. Henson Tsao, my high school classmate. He's from MGH and Harvard. Everybody knows Henson. And he is going to talk about adjuvant and neoadjuvant therapy approaches. And then if we have more time, Christina, maybe you can come back and show those cases. But thank you.
Susan already talks fast. Man, that is on high speed there. So anyways, Susan, I didn't get the email about the dress code. Chris and Doug and everyone looks so beautiful. Michael, I'm sorry, I'm in my Marshall with Henley here. So anyways, going to talk about adjuvant, neoadjuvant, and it's great that Christine talked a little bit about this, and I'll sort of go through it again, because this is probably some of the more innovative and exciting areas going on now. These are my disclosures. I love making images with AI, so you'll see some of that. So you've seen variations of these curves. Basically, as you sort of stage up, the survival goes down. There are some patients with such good survival, you really don't need any therapies of them. And those are probably the vast majority of the dermatology patients, certainly. And the goal of neoadjuvant and adjuvant treatment is try to boost those patients in the higher stages back up to a good survival place. So this is a time map of all the therapies and when they've sort of come out. And here we're looking at the approvals for the adjuvant use of those therapies. As you know, most drugs start with stage 4. Events are obviously more robust, and obviously the rationale for it is much more compelling. So I will start out, and this is the first time AI has actually created my patient Mel. It's sort of a realistic look. So I'm going to talk about several scenarios which you might come across to think about things. One, microscopic nodal disease, where you obviously can't see any nodes. High-risk stage 2 disease. Macroscopic disease, where they may have recurred after the primary excision. And finally, sort of macrosatellite in transit disease, which is quite rare. So I'm not really going to talk about that at this juncture. So let's start with microscopic disease. Here, obviously, you take that little node out with the blue dye, and you look at it pathologically. And according to the latest NCCN, if the deposit is less than 0.3, and again, Christine talked about these very minimal disease in the lymph node sort of ideas in survival, obviously observation is recommended. If it goes above 0.3 or stage 3A or B, consider imaging to make sure, again, if there's widespread disease, the idea of sort of going after stage 3 disease doesn't make sense anymore. You're looking at much more advanced nodal ultrasound in lieu of completion dissection, even though that can be done still in some settings. And then adjuvant treatment, and we heard a lot about adjuvant treatment towards the end of Dr. Angeli's conversation there. So observation is a possibility. So let's take a look at pembrolizumab as an adjuvant treatment. This is the 2024 follow-up for KEYNOTE-54. I'm just going to highlight a few things. The initial trial was about 500 pembro versus 500 placebo. Median follow-up 6.9 years. And with almost all adjuvant trials, it's relapse-free survival, because basically you have no disease to track. So at the time that you develop another nodule or another mass, then you sort of exit the trial. Why? Because then you're going to get treatment. If you completed that to a melanoma-specific survival endpoint, you can't give anything until that patient sort of dies from it. So just in terms of the ethics, it's quite challenging to keep overall survival as the primary endpoint. And also, again, once you develop a recurrence, there's an entire stage 4 sort of protocol to undergo. So these are the latest curves. You see at 7-year follow-up, pembro is 50% survival. Placebo 36, and a hazard ratio of 0.63. Hazard ratio is what most people look at for Kaplan-Meier. It is literally the probability of a recurrence or some event relative to placebo or the control arm. So This is 0.63. There's 63% chance of recurrence compared to not taking drug. So if you did the 100 minus that, that's the percent benefit you got getting out of the drug itself. So any hazard ratio under 1 is great. Any hazard ratio over 1 means that your drug is more toxic than it should be. So this is 0.69. If you look at the division of the 3 different types, stage 3A was not statistically significant, but 3B and 3C both were. Let's take a look at Nivo, another anti-PD-1 treatment here. This is Nivo versus Ipi. Ipi was the standard treatment at the time due to a lot of the studies Lex Egermont did. So this is about 450 in each arm. Again, relapse-free survival, median follow-up, 60 months roughly. This is in 2023. And here are the final numbers. 5-year relapse-free survival, 50 versus 39%, with a hazard ratio of 0.72. So Nivo did better than Ipi. Overall survival, no difference between the two. So CheckMate, this is a combination examination of adjuvant stage 3 and 4, combining both CheckMate 238 and DEORTC 18071. So if you look at the numbers, they really wanted to look at this mixed cure model, which basically say when you sort of look at that Kaplan-Meier curve, there's really 2 groups. One that were cured and another that was not cured. And the little trail off on the bottom suggests that the non-curers were sort of, undergoing attrition at the time. So when looking at this, I just want to really show you the sort of hazard curves from here. Most of the events, and you see this in the Kaplan-Meier curves, there's a huge drop-off in the first 6 months to a year. Those are patients that innately are not going to respond. So that was the non-curable sort of group. So this is something to sort of think about as we start stratifying and start analyzing these patients. Are there sort of fundamental differences between these 2 groups? And if you look at it, stage 3 patients and those under 65 are most likely to benefit from adjuvant treatment. BRAF-MEK, which is probably used much less commonly these days for BRAF mutated tumors. This is a COM-BAD with a final evaluation at 2024, about 450 again, placebo versus the combination, median follow-up 8 years, relapse-free survival, and these are the relapse-free curves. 48% on drug, 32% on placebo, with that hazard ratio of 0.52. And if you look at overall survival or melanoma-specific survival, again, no difference, 8 years overall survival, no difference melanoma-specific survival overall. One of the reasons, probably not so much what they got up front, but often after you relapse, you start getting really effective drugs. So this speaks to what Chris and Christine and a lot of people talk about. What is the point of relapse-free benefit if overall you're still going to get benefit later on if you recur? You're just treating them sort of slightly up front. So with salvage therapy, they did pretty well. Let's look at the high-risk stage 2. These are the patients that walk into your clinic and they have this 3, 4, 5 millimeter thick tumor sitting somewhere. Currently, wide resection is still the #1 surgical sort of approach. Sentinel lymph node biopsy, if it's positive, you go down that stage 3 sort of algorithm. And what happens if you're sentinel lymph node negative? So here you have no disease. Do we give treatment to prevent the onset of disease? That would be, again, adjuvant treatment. The 2 are pembrolizumab. It's also okay to give XRT potentially in certain areas, or there are probably trials ongoing right now. So let's look at pembro. This is Keynote 716. This is the 2024 follow-up. Looking at the stage breakdown, very few stage 2As, mostly 2B, 2C, and that's what the actual recommendations are going to talk about. All of them were sentinel lymph node negative. And those are the numbers, about 490 in each arm, primary endpoint relapse-free survival. And here you are with 36 months follow-up, relapse-free, 76% survival of pembro, 63% with placebo. If you did a ratio, that's 0.62. If you divided it, which is the difference in survival, that's about 12.8%. That's the delta. And here's 2B and 2C showing you the same data. They're all roughly with a hazard ratio of about 0.5, 0.6, but you can see the deltas kind of fluctuate between 12 and 13%. One thing to remember, if you have a large enough trial, and you go from 98% survival to 99%, that's a hazard ratio benefit of 0.5, right? But a statistical difference of 1% in survival. So the delta comes into play when you have really early disease to sort of think about, especially in the setting that 18% of these patients undergoing these treatments are going to have some kind of severe immune reaction overall. This is distant metastasis-free survival, 0.59. It is significant that the delta here is 9.7%. And you look at who responded, males and individuals under 65 experienced the most benefit. It's not that women don't respond necessarily, it's that their survival in general is better. So the actual benefit boost up is not statistically as robust as men who have, obviously have a poorer survival. So that sort of brought it, gave them a greater boost overall. So let's talk about Nivo versus placebo here in 2023. Checkmate 76K. This is adjuvant setting. This is a 2-to-1 trial with 526 Nivo versus 264. Intention to treat at 12 months relapse-free. 89% Nivo, 79% placebo, so a delta of 9.6 and a hazard ratio of 0.42. If you look at the separation between 2B and 2C, pretty similar overall, both statistically significant at 0.3 and 0.5 hazard ratios, each with a delta that's around 10%, a little bit less, a little bit more. This is the intent to treat distant metastasis-free survival, and here, 93% with Nivo, 86% with placebo with a delta of about 5.6. So those are the numbers at high risk, all right? Clearly some benefits with relapse-free survival. Clearly the numbers look better with a hazard ratio, a little bit sort of more real life when you look at the delta overall. And something obviously to think about, you don't that much in stage 4 for the oncologist, is the real chance of a side effect with these drugs, which can be quite obviously severe and sometimes irreversible. Let's look at macroscopic disease. There you got a little lump, say, in the lymph node. Core needle, fine needle, core biopsy or fine needle biopsy is obviously one way to go to establish the diagnosis. I've had patients who have metastatic breast cancer thinking it was melanoma because they have a mass. So, making sure the tissue in the lymph node is completely discernible and diagnosed before proceeding is obviously very critical. Imaging, as I said, there's widespread METs. It's a slightly different algorithm overall because there you're treating unresectable disease at the time. Therapeutic lymph node dissection can be done, all right, which you sort of remove things, and then you can give adjuvant at that point. You've removed disease. There's no evidence of disease. You're going down that track. The other side is the neoadjuvant approach, all right? And here, you give the drug up front, hopefully shrinking that tumor a little bit, and then you take it out to see what remains in that lymph node. And this is where I think Michael talked about how much pathological disease there is, complete cure versus partial versus, again, no response. At that point, you can give adjuvant, XRT, or observation. So what I really want to touch on in the last section is the neoadjuvant. I find that this is being used quite actively, certainly at my institution. So let's take a look at the data. Pembrolizumab, this is in 2023. Neoadjuvant plus adjuvant alone. I think this is one of the ones that really, one of the studies has sort of put this on the map. There have been smaller studies overall, but this one was really profound. 2 arms you can see, 150 roughly in each arm. One, you gave Pembro every 3 weeks, 3 times only. You took the nose out and you gave it 15 more weeks. The other one, you took the nose out and you gave it a total of 18 weeks. Same amount of Pembro, just broken up by giving 3 doses up front versus the rest after surgery. So that, in essence, is just the difference between neoadjuvant and adjuvant disease. And if you look at the relapse-free survival, huge differences here, 72 versus 49%. So if you gave it up front, clearly there was a much better relapse-free survival benefit compared to adjuvant treatment. If you looked at subgroups, almost all of them did better with neoadjuvant plus adjuvant compared to that alone. Nivo plus Ipi, this is in 2024, the Nadina trial came out, event-free survival. This is slightly complicated. You got this Ipi and Nivo for 2 doses, and then there was a question of path response, all right? Once you took the node out, there was a major path response, not much tumor left in the node at all, nothing happened. If there's a partial or no response, then you got some kind of adjuvant treatment afterwards. DNT if you have a BRAF mutation, or Nivo for 11 cycles. The other one, again, was the control arm with surgical removal and Nivo for 12 cycles. Pretty much the same graphs. Maybe they just colored it similarly, so it would remind you that these occurred, 84% versus 57% with a really significant hazard ratio. Didn't really make a difference between BRAF mutant and BRAF wild type overall. I think the critical point here is if you looked at it and stratified it based on pathological response, for those patients with a major pathological response, they didn't get any more treatment and their survival was 95%, all right? So just giving them a couple of doses, and if it completely shrank and you watched, these patients seem, at least in the interval, and that's a pretty short interval, so clearly longer-term follow-up is essential. It's really saying that you have that sort of high responsive tumor and that your survival is gonna be really good. Nivo plus relatlimab, this is a trial that came out in 2025, single arm. You had the two agents. That's an anti-LAG3, by the way. Sorry. The relatlimab, then you got the tumor out, and you had, again, the combination for 10 more cycles. This came out in 2022, and this was their initial, what's called the waterfall plot. And if you look at the partial response, 60% had complete response. So that's a pathological CR. And if you look now at the follow-up at 2025, and this is stratified in terms of markers, all right? Low TIGIT, high B7. So those on the right-hand side, if you look at the major path response, they maintained pre-disease free. Those with less than a major path response, obviously there were a lot more events. So again, they sort of, the corollary of this trial is whenever you're giving them in a neoadjuvant setting and you watch the actual mass, if it shrinks and disappears, that's a really good positive sign. Dabrafenib, trametinib, again, has been looked at in 2024. This is NeoCombi, and again, it's a single arm trial looking at giving some DNT twice a day for 12 weeks up front, removing the tumor, and then following up with 40 weeks. So survival is not the outcome here. It really is looking at the percent path response. And little less, but if you had a good path response, 53%, that was probably a combination of complete and partial. And if you had no path response whatsoever, survival was quite low. The log rank didn't really meet significance. These are small numbers. But again, echoes the theme that in the neoadjuvant setting, if you can document a robust reaction up front, generally the patients do better. And here, neither relapse-free survival or overall survival were significant if you really looked at it. So take-home messages. Adjuvant treatments are now showing significant relapse-free survival for those with stage 2B and above. Again, the conversation to have between relapse-free and overall survival is active, it's dynamic, and it's argued upon all the time. Neoadjuvant approaches are here. Again, in our institution is used quite a bit. The effect of overall survival or melanoma-specific survival is still being explored. And the question really becomes, if you treat now versus later and leads to the same outcome, then maybe there's unnecessary risks for toxicity. Sort of the idea being, and this is a thought experiment, if you can cure all melanomas and you just waited and then they developed a relapse and you gave them, they were all cured, it really wouldn't matter that you treated them up front. So it really comes down to the efficacy of that drug in the relapse setting. So biologically, if you think about it, if you gave it to them in a neoadjuvant setting and you somehow selected out resistors, then that's not a good that's not a good situation, because then you try to salvage them afterwards and they have less of a response. Or you can say, well, you gave them some drug and it tried to prime the immune system, so they tend to respond better. So that kind of, post-relapse survival on the same sort of agents, that's the kind of analysis that's probably going to make or break the overall survival numbers in our approach to these things. So with that, I'll stop. Thank you very much. And again, thank you for staying so late in this meeting. Stay here.
Yeah. So let me invite the other speakers up. Someone left glasses up here. You? We all need our readers. So I know we have about 10 minutes left for questions, and I don't know if folks have a lot of questions. I know there's been a bit of discussion about GEP in one of the other sessions just before this, or if we want Dr. Angeles to put up her two scenarios where she felt the Merlin test could be helpful. So a vote on questions versus new slides or whatever we can do. Chris is going to, Dr. Bajakian is going to stay after when I have to leave at 4 to field additional questions. But any questions offhand? And I'll have the panel come up. No questions. One question. And Christina, maybe I can put yours up, just because I think that's super interesting. I just wanted to be sure. Yeah, go ahead.
Survival versus long-term. I know the data is not in yet, but I think of President Carter, who they thought was in remission, but I think it was after 7 years, he had a recurrence. Do we have other data up to 7, 8 years on any of these studies to see what the effect is in terms of long-term survival?
You mean in the adjuvant setting? Like the overall survival in the adjuvant setting?
Yes.
Yeah, I think they're beginning to emerge. I don't know if in the latest ASCO anyone saw any of the longer-term follow-ups, but
Yeah, well, I mean, I'll let Christina also answer. We're still waiting on the overall survival benefit, and I don't remember his initial stage of disease, if he had stage 3. I know he progressed to stage 4 and was one of the, first high-profile responders to anti-PD-1 therapy in his 90s with minimal side effects, and he did not succumb to melanoma as his cause of death, to my knowledge.
I think it was a brain met too, right? So that
he
was
had
profound.
But he had that sort of typical thing where we see disease recurrence despite our best efforts, sometimes after even adjuvant therapy in the short term following diagnosis. But the long-term data on adjuvant therapy related overall survival is still pending. We know it improves relapse-free survival, and it's a big discussion our oncologists will have with patients. They may say, well, look, if the neoadjuvant data is looking so favorable, maybe I'll just wait until I recur, although that can have its downsides. As Dr. Angelos has said, it could be a much higher stage disease at that time. But they may wait till they recur, and if the therapy is going to do as well then, maybe you wait. So there's a lot of discussion in terms of timing immunotherapy, but upfront right now in stage 3 is kind of standard.
Can I just ask a related question, just with therapy? We've used in the past like a 5-year survival, but based on some of the information now available, are there patients who are doing fine at 5 years, but 7, 8, 9, 10 years relapse because of some cancer cell that did not respond to that therapy and now has grown and taken over?
I think if you look at the New England Journal, this is for stage 4, the chance of survival, if you made it to 3 years, is almost 96, 97%. All right, so there probably will be trail off. My bet is that because people start dying of other causes after 10 years, it's going to be really hard to follow that. But, there's clearly ultra-late relapses. I had a patient just last week who had melanoma in 1979 that relapsed this year. But those are rare events. The one thing with the really widespread disease in the stage 4s, if you make it to 3 years, which basically says the 2-compartment model I sort of talked about, there's the curable and non-curable, right? That's the 2 compartments. After 3 to 4 years, you've sort of cleared out the non-curables, and at that point, what remains, it looks like, is probably the curable group that remains. So,
thank you, and you had some very nice presentations.
thank you.
Oh, I think the gentleman right there was,
Yeah.
right up here.
First question regarding the sentinel node biopsy. It's been dogma for as long as it's been available that ought to be done in the same setting as the wide local excision. I think last year in this in a similar forum, a respected expert refuted that and even said, you could do the sentinel node biopsy anytime later, which was really in context of a dermatologist office. We're not doing sentinel node biopsies, but we're tempted to do the wide excisions. But it's not been my practice, but I know I've practiced with people who do that. And, I want to know what your feelings are on that.
Do you want to start?
You can negate the ability to identify a sentinel node accurately via preoperative lymphoscintigraphy if you've done a wide excision, if you've oriented even a large excisional biopsy, horizontally crossing over afferent lymphatics on extremities. And that can be problematic. We can follow that patient with nodal ultrasound, which is still a very excellent way to follow these patients who are eligible for sentinel node biopsy and either don't undergo the procedure for medical reasons or the procedure isn't technically successful. But it's not optimal. Patients are unhappy. If they come to you and you say, we can try the sentinel node now, it might not work. And we typically would have done this at the time of the wider surgery. Now, there is one study looking at Mohs surgery talking about the fact that If Mohs is done in patients who are sentinel node eligible, it can be done and not sort of disrupt that opportunity. But in that study, at least 85% of the patients underwent sentinel node biopsy first and then went to the Mohs surgeon to have those cleared. Okay, that's a different way to do it. It's asynchronous surgery. Is that valuable? We'll know down the line as we understand margin control and what the Mohs is offering. But I think ultimately, if for the patient's best interest, the procedure should be done in the same operative setting to maximize the accuracy of the procedure as a pathologic staging tool. And
Yeah, I have lots of patients that they won't map after wide excision, or when, especially on the trunk or the chest, we don't know if it's going to the right place. What if it goes to one site, but maybe it should have went to two, but the lymphatics over there are cut and scarred?
Well, it certainly validates my practice. The other thing is in this whole context of neoadjuvant immunotherapies and other therapies, but just neoadjuvant, if you don't have to take out the tumor burden in the lymph node, why do you have to take out the tumor burden in the skin? In other words, is the wide local excision even necessary?
It's being studied for stage 2. I mean, it's
Right,
being studied.
it's being studied. There is a lot of thoughts about that for the high-risk patients, that just giving immunotherapy up front and then seeing if you have a complete pathologic response, whether it's in the primary or the node, right? What we want to do is train the immune system, right, to make those T cells have memory so we don't have recurrence. So this is all being studied, but it's not standard of care yet. It's in clinical trials.
I look forward to next year.
Yeah, I just want to extend that thought for a second. I mean, the idea is that you have tumor-reactive lymphocytes on site being trained while you give them immunotherapy. So, treat while the thing's still on the skin, treat while the mass is in the lymph node. And people have asked them, why not treat when you have a sentinel lymph node, microscopic disease? Would that be helpful? Then the whole idea becomes, maybe we should just treat first without doing a sentinel lymph node.
That's right.
And maybe that'll give a bigger result in the end.
Well, that was the scenario I presented initially, this patient with occult disease, but high-risk primary, stage 2C, but PET CT showed something, we could identify the nodes, do the FNA, and did neoadjuvant. I think it's interesting, we've had patients who come to us not infrequently billed as a stage 2C, big bulky tumor on the skin, who then have an obvious nodal met that we can feel. We find needle aspirate it in clinic, prove it, they see the surgeon and the oncologist bypassing, again, our side of things on the front end of disease. And those patients who get neoadjuvant invariably have shrinkage of the tumor on the skin. And when it comes out, it's not nearly as, we don't generally do a 2-centimeter margin. We're kind of saying, let's just get it out now with a centimeter margin. A lot of the time it's just necrotic tissue, no viable melanocytes. So does that have the same prognostic significance as the node, as we now know with the major pathologic response? But it's coming. It's going to be studied in injectables with an RP1 or RP2 agent in the skin for stage 2 disease. And so I think it's an exciting time. We may reduce surgery overall. Yeah. Sorry.
Thank you.
Yeah, no, I think this is really exciting.
I'm going to step out, but please keep going. And I want to thank everyone. And Chris, do you mind taking over the panel moderation?
We're at time, are you sure?
If you guys are okay, just a couple more questions.
Yep.
Yeah, sure.
I just started using the GEP testing, but I'm only using it in kind of one place. I found the sentinel lymph nodes to be unreliable on the head and neck.
Yeah.
So I've only been using it in that population, tumor stage T1A with the base positive up to 3s, just because I find it unreliable. I've had a lot of recurrences even with negative sentinel nodes. So I don't know what your thought is on that, particularly head and neck. And I haven't seen anybody specifically looking at that population with the GEPs. So I just want to know your thoughts and your take on that approach.
Yeah, so when I first talked about sentinel lymph node and I gave that 98% sensitivity, that's in, all comers. But if you look at just head and neck, that goes down to about 85%. So there are a lot of head and neck sentinel lymph nodes that are missed for that, just because of the mapping, et cetera, et cetera. So that is one area that, we've been thinking about the results of the Merlin test, because in head and neck melanoma, they were actually better than sentinel lymph node in many, when they looked retrospectively at some of the published data for head and neck, that they could pick out the low risk and high risk a little bit better. So that is something that I think could be very useful. I think whenever we think about using the GEP test, though, it's a discussion with the patient, because there's still a risk, right? It's not like you can say there's zero risk it's being there, and if it's a high risk, and even in the setting of high risk, it's not 100%, right? So I think in that, but I do think there's going to be more clinical utility right now, especially with the Merlin test with head and neck and the older patients and the T1Bs specifically. Yeah. I can go through this. I know it's that time you guys can leave, but I just, when we use this in the test, the NCCN guidelines say that you refer to the surgical oncologist, and we use the Merlin test as how to make a decision. So, this particular patient that I had was, a lot of comorbidities, high risk on Eliquis, had a mid-back. So this is those patients that can map to 4 different areas. So the surgical risk goes up in a patient like this. And I used the nomograms, and we had, 12% risk in the Memorial. The MIA was about a 10% risk. So that hits above the 10% risk. And I said to him, but he's above 65, and the morbidity would be higher. So, when you think about what the Merlin test is for a T2A, a low risk would be about 8%. And I said that to him. I said, and I feel good about this data, so would an 8% risk make him feel okay not taking the morbidity of surgery? And then when you look at just all comers greater than 65, that becomes, even lower. So, but I told him 8%, and then when I sent it, it came back as low risk, right, and 8%. And he decided to do wide local excision alone. He understands an 8% risk, right? And then we discuss full skin checks, neural exam, and I tell the patients, maybe you do fall into that, right, 8%. Maybe you do have a positive sentinel lymph node. If we pick it up and we identify it, we have good treatments in our toolbox, where I can tell you when I was in training, or even 10 years ago, we didn't have good, right? And I think this is one of the things with surgeons. We wanted to do more and more surgery because if we lost control, we had no good therapies. Today, we do. You just heard about them. So I think we have to think about being a little bit more mindful when we treat patients. Here's another patient, 65, COPD, just had an MI a few years ago, didn't look like a good surgical candidate, but we could get him through. It could be okay. Left arm, 1.3, no ulceration. I was like, okay, so this is a lower risk, but still by the nomograms, 8 and 9%. I said, okay, so you're less than 10%. But I sent, thinking about, this again, it came back as 19%, right? So in this case, I said, well, you know what, maybe we should do it, and it was positive. So it's still, he falls into the 3A. So we said a good 3A. I don't have it was less than 0.3, so he's actually, right, better if you think about that lymph node amount. But we're surveying him, right? With the other patient, we're not surveying. This one we're surveying with ultrasound, PET scan yearly, et cetera, et cetera. So just to give you an idea, and this is not all, I don't use it on all my patients. I use it on the patients when we have the discussion, because I have some patients that are like, no, I'm more than 5%, I want to be in the operating room, then the Merlin test isn't going to help me with those patients, right? It's the ones that that don't really want to take the risk of anesthesia going in the operating room. They don't want the potential morbidity, et cetera, et cetera. So it's a tool that we use. Now, as time goes on and we get the longer term follow-up data, this is what I said. So we have the numbers from like sentinel lymph node biopsy, positive, negative in different groups, but we're going to look at all these other things, right? Recurrence, for negative sentinel lymph node recurrence. We're going to look at adjuvant therapies because, we have 1,700 patients. A lot of those patients did or did not get adjuvant therapy. We have all that data that we're following, and we'll be able to see survival. So prospectively following all these patients, we're going to really be able to see that data in the coming years. So we're really excited about that. Also, we're following them. So definitely, we have 720 patients. Not all of them were positive, but the ones that then were followed and then recurred and got neoadjuvant therapy, all of this data is being collected. So I think it's going to be exciting what we see in the future. And I just think that we have to think, I said it before, but any clinical trials that we do, we really have to think about building this into that so we can prospectively see if we're picking up that high risk, low risk. Because the Merlin was designed to forego sentinel lymph node, but now let's think about that high risk. Can we pull out the high risk patients? And that's something we can do. And I think we're going to get a lot of those T1As with the Iceman trial too, which is going to be able to inform that population. That's also hard. How do you really identify that high-risk population? The last thing I'm going to end with in terms of nomograms versus the Merlin trial, there was an abstract presented at the European Society of Surgical Oncology last year where they looked at the T1Bs, T2As in the in terms of, where is the benefit of using the CPGEP, the Merlin test, versus nomograms. And sentinel lymph node biopsy is the best way to pick up less than 5%, right? Nomograms don't do it. Merlin test does it. Nothing does it, okay? If a patient, you want to know the 5% cutoff, you have to do a sentinel lymph node biopsy. But if you're okay with that 6 to 7% as your cutoff, the Merlin test does do better than all the nomograms, right? In the T1B, T2As, if you're okay with that number. And so that's something that we have to discuss, and you have to discuss with your patient.
One quick question for you.
Yeah.
And by the way, hi. What if you just did nodal ultrasounds?
Yeah,
And
that's
just
interesting.
every 3 months and just skip all this stuff.
Yeah. So
and then you just do something when it comes up.
So this is what I want to tell you. In the state of Michigan, we see a lot of the melanoma patients, and a lot of my patients who get nodal ultrasounds, they live 2 and 3 hours away. They don't want to drive to see me,
Okay.
so I try to get them to do it local. They can't do it.
Okay, so it's,
Training ultrasonographers to do that nuance, they have to be high volume, and they have to know how to do it. I actually can't get our community hospitals and other hospitals to do it successfully. And if you don't do it well, you're going to miss.
okay.
So that's the current thing. I mean, if we could get, and I think a lot of radiology departments just don't have, like we had to hire a lot of ultrasonographers with our volume.
Okay.
Yeah. All right.
All right.
Thanks.
Thank you all for staying. It's been a pleasure having you all here. Safe travels to where you're from. Thank you.
No, not at all. I could get you to lecture. Maybe by Zoom, we have a melanoma lecture series then. Because I think the way you sort of spelled out Merlin, first of all, you have experience. I don't think we've ever used it yet.
Yeah.
Just to understand where it's helpful or not.
Yeah.
You know,
I had a lot more other examples, but I tried to just do two. That was
Did they not?
Janvier, Kentanov.
yeah, they don't use it. Yeah,
They
John,
don't
we have
use
an
it.
IR buddies.
Yes, I don't
She
think
and I are
they use
real
it.
good
'Cause I've
buddies.
never
No, they
seen.
don't. No, they don't.
They weren't, and they were not part of the trust?
No.
Intentionally?
There was only so many places that they could do it, and they tried to diversify throughout the country. So.
But doesn't mean we shouldn't do it. It just
That's
means
what
we
I'm
don't
asking.
have the
You
evidence.
Order it, but I mean, Pat sends it, right? I mean, you put in the
Oh,
order.
anyone could order. it.
So in
just have
Epic,
to
you
have-
just go.
Oh, no,
no, it doesn't work that
It's
way.
kind of like Tempest.
Okay.
Do you know Tempest?
We don't use
Yeah,
that.
so in oncology, like, it's not, you have to like fill out a form. and
I see,
fax it.
okay.
They would, oh, sorry.